if you're happy to set the record, and if you're all happy just to click got it, then we'll start. So good morning, everybody, and welcome. Thank you so much for joining us today for this event. The event is titled Understanding Conception and Fertility After Early Pregnancy Loss. And just a quick introduction, I'm Louise Dredge. I am a support coordinator with MIS, and I'm going to be the chair today for you. So I'll be guiding you through the day, introducing all of our speakers, which we are really grateful for all of our speakers for joining us here today, sharing their knowledge and putting the time and effort in for us. I'll be giving you a little brief description of the topic that they will be discussing. And as you can see there, the hashtag has been set up with this event, hashtag you are not alone. This is really what we aim to make people feel at MIS, is that we want to create a safe space where you can discuss anything you need to discuss, ask any questions, and yeah, just gain some knowledge and hope to carry you through your journey, whether that is through a fertility journey or trying to conceive again after an early pregnancy loss. So this event was set up as a collaboration between MIS itself, the University of Aberdeen, and also NHS Grampian. And we are going to be bringing you a variety of topics relating to preconception advice, the latest research into fertility and conception after a pregnancy loss. So obviously MIS is a miscarriage support service covering all of Scotland for anyone who has experienced baby loss. We offer that confidential space for anyone in Scotland to receive support that they may need, information and advice, as well as understand that you're not alone after going through a miscarriage, as we quite often can feel. We can feel quite isolated. MIS, of course, was set up by our founder, Abby Clark, in 2017 after she suffered her own loss and just found that the support and information was lacking in the area. We also have with us today Victoria Goldie, who is the operations manager at MIS. Morning, Victoria, and she has been coordinating with the staff at NHS Grampian and the University of Aberdeen to organise this event for men and women, families who are trying to conceive after experiencing a miscarriage. And we really hope that this event will provide you with information on understanding the factors affecting miscarriage, recurrent miscarriage, and some of the latest research on fertility and conception. And of course, each speaker will provide you with information on a topic, and you will also have the opportunity to ask anonymous questions at the end of each presentation. We ask that you keep questions until this point, just in order to allow the presentations to flow more easily. So if you need to maybe keep a little note of your question on a piece of paper in front of you and then ask it at the end. So to do the anonymous questions, we are going to be using a website which you can access on your mobile phone, so that you can log onto the website through your internet browser, send a question, and we'll be able to put it directly to the speakers. If you have any difficulty with that, please just pop it confidentially in the chat box to either myself or to Victoria. You can choose that option in the chat. We also aim to have some short comfort breaks throughout the morning. And yeah, I hope you enjoy it. I hope you get lots from it. And so without further ado, it is my pleasure to announce our first speaker, Dr. Andrea from the University of Aberdeen. Andrea is a senior clinical lecturer. She's also the early pregnancy lead at the Aberdeen Centre for Women's Health Research, and she also works with Aberdeen Maternity Hospital. The subject that she is going to be talking about is all things progesterone. So I will stop my share so that it allows Andrea to come up and to share her screen.
Hopefully you can see my slides there. Can we get a excellent, super. I'll just start slideshow. Right, is it switched to the slideshow mode there? Perfect. So thanks, Louise, very much for the introduction, and apologies, I changed the title slightly there. I'm not sure why, but absolutely, it's all about progesterone. And as Louise has very kindly introduced me already, I work as a senior clinical lecturer at the Aberdeen Centre for Women's Health Research at the University of Aberdeen, but I'm also a consultant obstetrician and early pregnancy lead for NHS Grampian at Aberdeen Maternity Hospital. So what I thought I would do first of all, because I suspect many of the people in the audience have heard about progesterone, and there's been lots in the media, there's been lots across miscarriage charities, lots of discussion about progesterone. And I hope what I will give you is a very honest review of where we're at with progesterone, what we know and what we don't know. So I've pinched this lovely picture from Google and I've put the reference there down at the bottom. So this is definitely not my work, but I thought it was a really nice picture. Just to kind of highlight that we all have progesterone, as I'm sure many of you know, or people who menstruate rather have progesterone in their bodies. Every month, progesterone is involved in your cycle. And so you can see here, the blue line is estrogen, and estrogen is more prevalent in that first half of your cycle, these first 2 weeks, and then it starts to go back, or rather it rises into that second week and then goes back down in the third and fourth week of cycles. And progesterone sort of does the opposite. It's at a certain level in those first 2 weeks. So day one is your period, so menstruation here, so period happens here, progesterone is sort of static, and then it goes up in the second half of the cycle as that uterine lining, so your endometrium, what we call endometrium, the lining of the womb, is getting thicker and thicker. In that second part of the cycle, progesterone rises, and progesterone stays elevated until just before then the period comes and that lining is shed, which is of course what our periods are. So this is a normal process, and you can see when women ovulate, so when the egg is released, again, after that, that's when the progesterone rises. So I just thought it was helpful to have that kind of overview of what actually is progesterone and how does it work normally. In early pregnancy, we know that progesterone is very, very important. So that rise you get in your progesterone as your endometrium gets ready to accept a fertilized egg, if you like, so an embryo. That's why your lining gets thicker at that latter part of your period cycle. But then if that doesn't happen, then your period comes and the lining is shed. So what happens is that elevated progesterone that you saw in the graph there, if you get pregnant and the embryo then implants in the womb, then that progesterone stays higher. And actually, again, this is a pinched picture from Michigan State University, a website called Repropedia, which had these lovely images. So what happens there, you can see here, I hope you can see my cursor. Can you see my cursor on the screen, Louise? Yeah. So everybody in their ovaries has got lots of follicles that are at different stages of development. And I'm really conscious Ashley, our next speaker, is a fertility expert, so she might laugh at my very basic explanations here, but bear with me. So all of us have eggs, and in fact, our eggs are in our ovaries from when we are in our mother's wombs. Quite fascinating. Anyway, so you've got all these follicles that are at different stages of development in the ovary. And one of those follicles, generally speaking, if you're going to ovulate that month, will mature and it will release an egg. And what happens to that follicle, we believe, after the egg is released, is what's called a corpus luteum develops. And we believe that produces a lot of progesterone in those early stages in pregnancy. And you can see here that's shown on the picture here. And if the egg is not fertilized and you don't fall pregnant, then that corpus luteum just sort of goes away. But the idea is that if you become pregnant, that corpus luteum would continue. And it releases other things as well. It's thought that it also produces estrogen as well as other hormones, but certainly thought to produce progesterone. So, theories. So because, of course, we don't understand a lot about miscarriage, and we certainly don't understand a lot about recurrent miscarriage, several theories have been brought up in research as to how progesterone might be involved in miscarriage and pregnancies that don't carry on. So what we have wondered, we being the royal we there, I haven't been involved in any of this research, I should make that clear. I have no disclosure of interest, I'm just purely describing the research that's out there, none of this is my work. But people have hypothesized that, do some women produce less progesterone? And is that why they repeatedly miscarry? Do some women have defective corpus luteum formation? Does it not form right? Who knows? And is that why maybe some women repeatedly miscarry? But it's hard because progesterone will be low in a pregnancy which is not continuing. So pregnancy that's already miscarried or is about to miscarry, you might imagine your progesterone level might actually already be going down. And is it the cause or is it the consequence? So is it because you're miscarrying already because of some other reason, or is that what's causing the miscarriage? We don't really know. And of course, most miscarriages are thought to be due to problems in the baby's genes, problems in the baby's genetic makeup. Around half, we think, are to do with that. So of course, progesterone won't stop that. So it's difficult to know, but there have certainly been several theories, and that is why progesterone has been suggested as a potential treatment for prevention of miscarriage. So before I talk a little bit more about the research that's been done on progesterone as a treatment to prevent miscarriage, I thought I would just briefly talk about what is a trial, because I'm going to say the word trial. And you may have heard the word trial, and it's difficult in these online seminars because I would love to ask you all to put your hands up who knows what a trial is, or who's heard the word trial when they've been looking at information on websites, on myths, on Tommies. Have you heard that word, and what does it actually mean? But it's a bit hard on the online thing. But if you can, I don't know, show me a thumbs up or something just to know if you've heard that word before. That would be great. I'm not seeing anything, so I'll carry on with my description. So a trial is a type of research study that's done where we take usually two groups, sometimes more than two groups, of women with the same problem. So with the same condition, not women, but people with the same condition. And basically you are testing something. So you're testing treatment A or treatment B. And so what you do is you take a random group of women, or the best trials are done what we call randomized control trials. They're thought to be the most high quality. And you take a random group of women with the same condition and you randomly allocate them to A or B. And the idea is that by randomly allocating women to one treatment or the other, you should in theory have two groups which are the same. You should have two groups who have a mixture of ages, mixture of other health conditions, mixture of their weight, lots of other characteristics. But because it's done randomly, the theory is that you should have two identical groups. So you have two identical groups, and therefore you will get the answer, which treatment is better, A or B. That's the idea. So it's really one of the highest quality research studies you can do. And there have been multiple randomized control trials looking at progesterone for miscarriage. And I'm going to speak about two primarily, but I'm going to also speak more generally about some of the other published work as well. Okay, so hopefully we've got a bit more information about what a trial is, and apologies, I will say that word a lot. So we'll talk now about more specifically progesterone evidence. So there are two key groups to consider currently, with current recommendations and the research that's been done to date. First is women who present with what's called threatened miscarriage. So they have bleeding, but at that moment in time, they have an ongoing pregnancy. And we'll talk about that group first. And then we'll move on to talk about women who have had recurrent miscarriages, who have no symptoms. So they don't have any bleeding or pain, but they have a history of recurrent miscarriages. So that first group, so threatened miscarriage is really common. Lots and lots of women have bleeding in early pregnancy. We think up to 1 in 5, but it may even be higher than that because we don't really have great estimates. But we think it's certainly at least around 20%, if not more. And actually, most of those women, there's no problems and everything's okay, and the pregnancy will continue. You can have implantation bleeding really early in pregnancy, which is completely normal. It's just when the pregnancy implants, you get a bit of bleeding. That's sometimes why people can get their dates mixed up, because they think, oh, I had a period though, but it wasn't a period. It was implantation bleeding. Excuse me. However, we do know that obviously, and I'm sure this group doesn't need to be reminded of that women who have bleeding can then go on and miscarry their pregnancy. So one particular trial called the PRISM trial looked at giving progesterone to this group of women. So women who presented to the early pregnancy unit with bleeding, who had a scan. And that's a really key thing I want you to remember. They had a scan first. And what they found, so this is taken from the Tommy's website, who didn't actually directly fund the trial, but the researchers and the professor who led the trial work at the Tommy Centre in Birmingham. So they have a lot of information about this trial on their website. So what they found at the top of the screen there in the navy box, if you had no previous miscarriages, you were in your first or not necessarily a first pregnancy, but a pregnancy where you have never had a miscarriage before, there was really very little benefit, in fact, no benefit at all, of taking progesterone if you presented with a threatened miscarriage. So again, at that moment in time, you have bleeding, but the pregnancy is ongoing. They found that there was a small benefit if you'd had one previous miscarriage and 1 to 2 previous miscarriages. They found that 5% more women in the progesterone group, so the red kind of colour is the progesterone group, the green colour is the placebo group. So remember I talked about treatment A and treatment B, that's exactly what they've done here. You got progesterone and you got a fake tablet, which is called a placebo. And so they found this 5% difference. Women who had 3 or more miscarriages, they found actually a much bigger difference, and you can see that there in the graph. How you describe what's a significant difference and what's not a significant difference in research is very debated, and a lot of it depends on the condition in question and what matters to the people with that condition. And so here I would say, I think most people would agree there was a substantial benefit there seen for women who'd had 3 or more miscarriages. And the drug that they used was something called Progesterone, which is a micronized progesterone. I'm going to speak about that in a little while again. So this trial was a good trial. It was a high quality trial and it included lots of women, and it was powered to look at the question, does progesterone prevent miscarriage in women with threatened miscarriage? So essentially what I'm saying is if anybody was going to answer that question, it's this trial, because it was good. It was a well conducted trial, as far as we can tell. And that's the publication there for it. Couple of things to highlight, however. As I mentioned already, every woman in that trial had a scan. And that is really key because progesterone does have some risks. I highlight here on this graph, so this looks super complicated, and I can feel Louise going, oh gosh, she's going all sciencey on us, what's she doing? So this graph is taken directly from that research presentation, and all I need you to know, you don't need to know the lots and lots about this and what this all means, but you can see at the bottom, the very bottom of the screen, it says placebo better on one side, progesterone better on the other side. So basically, this is a summary of that trial's results and what it's showing. And if the line, see all these black lines that are going funny angles, if it crosses the line, that means that actually that's, in research terms, not a significant result. If it's all on the side progesterone better, that means progesterone was better. So you can see here on that circle I've drawn that for 3 or more miscarriages, it would seem progesterone was indeed better. For 1 to 2, it crosses the line. The evidence is less clear, but nonetheless, the effect size seems to be more on the progesterone side. And for women who'd never had a previous miscarriage, you can see very clearly there, it crosses the line and that box is in the middle. It did not work. It didn't do anything. Now, the gestation at presentation, so when those women attended with bleeding, that's what this is talking about. When they arrived at the point at the early pregnancy unit with bleeding, and how many weeks they were. So what this is showing you is that those with very early bleeding, so the less than 6 weeks, again, it didn't actually make any difference. It crosses the line. Yes, the effect size is more towards progesterone, but overall what we're seeing there is that it didn't make a huge amount of difference. It did, however, make a difference. You can see that line, my cursor keeps going a bit crazy here, apologies. This line here is all on the progesterone side. So the women who presented between 6 and under 9 weeks, it seemed again to be more effective. And those with later presentations, so more than or equal to 9 weeks, unfortunately, we see there it wasn't as effective. Age and BMI, many of you will be aware, are risk factors for miscarriage. And we didn't really see in this trial that there was any major differences. So again, all the lines cross. So when you looked at women who were over 35 versus under 35, they didn't really see any differences in those groups. So, which is helpful to know for us then thinking about how we use this treatment. And also, again, similarly, whether or not there was a heartbeat present at the time of that initial scan. So what does this all mean? Well, NICE guidance, which is our big medical governing body, if you like, or not really governing body, but they sort of produce clinical guidance for lots of things in healthcare. And it's a national institute that sort of states what recommendations, and it's like, you know, they're produced by multiple people and they look at all the evidence. Now, essentially, most of the evidence that's in the NICE guideline comes from this one single trial, but they essentially have suggested that for women who have a confirmed pregnancy in the womb, that we should be offering micronized vaginal progesterone for women who've had a previous miscarriage. So you can see that there hopefully on the screen. And they do suggest continuing that to 16 weeks, which I'll touch on in just a wee second. So that's taken directly from NICE. I've copy and pasted that from the NICE guidance. Are there any risks? Well, what is the risk of giving without an ultrasound is something I'm often asked. It's difficult because the trial in this particular, for this particular reason, for women with bleeding, was done in women who had a scan. And the issue is, if we don't see that normally cited pregnancy, so the pregnancy in the womb, the worry is that we could give it to women who actually have an ectopic pregnancy. Now, 1 in 80 pregnancies are ectopic, and actually progesterone could be contraindicated in that case, because we don't want to be encouraging ectopic pregnancies to grow, because then they risk causing problems and life-threatening problems. So that's really why we want a scan. We want to know that that pregnancy is in the correct place. There is also a concern about, could we prolong a miscarriage by giving them progesterone? As I mentioned at the start, we don't really know. Is the decreasing progesterone levels we see with miscarriage the cause or the consequence? Is that actually something that's happening because the pregnancy is already unfortunately going to miscarry? And so there is a worry, and we don't have evidence on this yet, but there is a worry that could be, if we gave lots of women progesterone, actually mean that the miscarriage isn't picked up until later, which of course is not always, women wouldn't want that, I don't think either, but again, would love to hear your views on all of this. We've spoken about the time, the number of weeks you are when you present with your bleeding, and the other thing to just mention is that there are no studies that have looked at long-term effects on the children born. So as I mentioned, 2/3 of women will go on and have a normal pregnancy after bleeding. And there isn't really that long-term research on what effect high-dose progesterone in women who've got pregnant themselves, not through IVF or any other treatment, what that has. The 2 trials that were done didn't find evidence of harm, but they weren't powered, they weren't big enough to actually look for that. So from a statistical probability point of view, they weren't actually big enough to look at that, because you need massive samples to look at that. But they didn't find any harm, which is reassuring in itself. 12 and 16 weeks. So here in NHS Grampian, we are actually recommending treatment till 12 weeks. Please do speak to us if you're not happy with that. We will absolutely help you and want to discuss, your wishes. NICE has gone with 16 because that's what the trial did. But across Scotland, we've had discussions, and there isn't a clear biological reason for why we would continue to 16 weeks. And as I showed you there in that fancy graph, actually the effect was there by sort of 9 weeks. And so there is this concern that actually taking it for longer, and again, when lots of things are developing in babies in these really early stages of pregnancy, organs, hormonal function, lots of things, we do have to be conscious. Any drug that you take in that first trimester, we have to be careful about this. So that's one key thing, I guess, or difference in what we're doing. And the really key message is it has to be micronized progesterone only. There are multiple studies that have looked at other types of progesterones, injectable progesterones, all different types, and particularly something called progestogens. They do not work. We have had multiple trials where they showed clearly they did not work. So the only thing that has been shown is this micronized progesterone, and I've given the names of the 2 that we currently have got allowance to use in NHS Grampian. So that's just our policy there. As I've described, we are following NICE guidance in Grampian for threatened miscarriage. We will be offering progesterone for women who meet those criteria, but the criteria is there for a reason. I hope that's come across. We are following the evidence that's there in the study. And again, happy to take questions on any of that. So just very briefly, the other group is the group of women who we would be offering progesterone to is women who have no symptoms, but have had a previous history of recurrent miscarriage. So again, I'm going to use that trial word. So there is one key trial to know about. Again, it was an excellent trial. It was well conducted. It's the same authors that conducted the PRISM trial, which is the threatened miscarriage one. It was planned well. It was, as far as we can tell, again, a high quality trial. Now, it's a bit conflicting because I've put at the top of my slide there that the recent Lancet, so Lancet's one of the biggest medical journals that there is, they published a series of papers, which I'm sure many of you have heard of, with a lot of the Tommy's Clinic authors, Tommy's Clinic professors as the authors. And they've suggested we should be offering progesterone to women with 4 or more miscarriages from the point of positive pregnancy test, so not requiring a scan. And a lot of them were involved in this trial. So what this trial did, back to treatment A and B, they gave progesterone versus placebo, again, a fake tablet. You didn't know what you were getting. The women that participated in that trial were unaware. Women had to have had 3 or more miscarriages. And when they were pregnant, in their next pregnancy, they were given either progesterone or placebo. Again, it was a randomized controlled trial, the highest quality one. But unfortunately, this trial, and I've taken this word for word from their paper, from what was published, and the headline that was published from that was that unfortunately they found that it did not work. It didn't prevent miscarriage in these women. So then I come back to that first line of my slides. Well, why are we offering it? Well, again, similar to the PRISM trial, when women had had higher numbers of miscarriages, we saw a slight difference. We saw that graph, and I haven't put up the graph from Promise, but I've put some of the results here. We saw that there was a slight trend. In terms of numbers, at the very top of the screen, so again, this is taken directly from that paper. So you can see here that the live birth rate, so women who went on and had a continuing pregnancy and had a baby, in the progesterone group was 65.8%. In the placebo groups, the group that got the fake tablet, it was 63.3. So very small, but nonetheless difference there. And so why the Lancet are recommending we offer to women with 4 or more miscarriage is because there is this effect size seen again with women who had multiple miscarriages. Equally, statistically speaking, there was not a significant difference. But again, there is this thought that maybe it's doing something. So what are we doing in Grampian? Well, as I've mentioned, we are using progesterone until 12 weeks. That has just been approved online this week. It's up on our sort of clinical guidance just this week. So that is very new, hot off the press, as it were. We've been working on it for 2 years. Actually, before the NICE guidance came out, we've been working on that. But that is in place now. And we have gone for 12 weeks as the recommended duration of treatment. As I say, that is because after lots of discussions across groups in Scotland, we felt we didn't have a strong enough reason to suggest it needs to stay until 60 weeks. And from that trial itself, we feel that that evidence isn't clear why you would need to continue it. But we will support choice, and it's there in the NICE guidance. And if you want to discuss that with us, we'd be more than happy to. And it's in line with assisted reproduction treatment. So we felt it was easier and simpler to keep everybody on progesterone until 12 weeks. That includes the women who are on it for IVF reasons, for completely different reasons. And as I've mentioned, we are using the 2 drugs mentioned there, which are both micronized vaginal progesterone. So absolutely in keeping with guidance. And this is just to kind of show you who we do and do not offer progesterone to currently. That may change, but this is what we're going with at the moment because that's what the science is telling us. So we're not giving it in first natural pregnancies. Yes, lots of women get it for IVF pregnancies, but we are not recommending progesterone in your first pregnancy. We're not recommending it for women who have bleeding and have never had a miscarriage before. And we absolutely are not giving it in any women where pregnancy of unknown location, so where we don't know where the pregnancy is yet, or where there's a suspected ectopic pregnancy. We are offering it to women who come to the recurrent miscarriage clinic and have 4 or more miscarriages, and we talk about it as well with women who've had 3 miscarriages, and we make a plan together. You know, we are very much supporting choice there, but I wouldn't recommend it under that. As I say, the trial very clearly showed it didn't actually make a difference to women with 3 or more miscarriages. So that's just really to, where we're at. As I say, it might change. Even very quickly, we might get more evidence that changes what we're doing, but that's where we're at right now. What we still need to know, so we need to know if progesterone is safe. It would be wonderful if it was found to be safe and we could use it much more. Equally, we need to know that. We need to know that it's safe for babies to be exposed to progesterone. And so I'm certainly looking at doing some work looking at that. If anyone is interested in taking part in some what's called public and patient involvement in my research proposals, I would love to hear from you on my email address there. We need to know which women will benefit from progesterone. So we've shown there it's not big differences. Progesterone is not going to stop every miscarriage. We know that. I wish it would, but we know that it's not going to from the studies that have been done. So we need to know which women would benefit. Is there a way of knowing who might benefit from progesterone? And again, I have some work around that, and I would love some involvement. You don't need to know anything about science or research. I just would love to hear from you if you're interested in knowing more about that. And it's to do with sort of proposing the research, so developing what research we will plan to do. And are there particular women who maybe have genes that are linked to a progesterone that might affect the risk of miscarriage? Who knows? We don't know. So take-home messages. Progesterone might help some women. It is being offered in NHS Grampian, but only as described. There is limited evidence for its benefit, and there's limited evidence on its harm, but at the moment, we're not aware of any definite risks of harm, which is good, but equally, there haven't been those big studies that we really need to definitely answer that question. Please don't take progesterone that you're not prescribed. Do not buy progesterone online, please. And it's micronized progesterone only that is currently recommended, none of the other multiple types. They have been studied lots and lots and very clearly showed they definitely don't work. And that's me.
Thank you so much, Andrea. Is it okay if I ask you to stop your screen share?
Oh, yeah.
Thank you so much. And then what I can do is I can pop up the website for people to go to so that they can ask any questions if they don't feel comfortable doing it in a more public setting. So as I said earlier, if you find it difficult to access this, you are more than welcome to send a private message to either myself or Victoria Goldie. But if not, this is an opportunity for you to ask a question completely anonymously. Anything mentioned by Andrea in her presentation, any questions that have popped up, maybe about progesterone, what you do is you go into your web browser in your phone, type in this website here, www.menti.com, and what will happen is a little box will pop up and you can type in the code. And I'll show you the code in a little second. It will be across the top of your screen. So 8292 2481. And what will happen is you'll have an opportunity to write a question into the box and send it off. That was really interesting, Andrea. I've heard about progesterone being offered quite a lot, but actually was really unaware that the evidence suggests that there is quite a small group of women that it will benefit.
Yeah, and it's it's hard, Louise, because of course we absolutely want treatments. We want to be offering something. We want to have some. But equally, as I said at the very start, I'm half scientist, half doctor, if you like. I'm a hybrid. And with anything in medicine, we conduct, and I say these high quality trials, they couldn't have been better. I mean, that's me. I wasn't anything to do with this research. As I said, they were good trials, and that's the answers we've got. And trials aren't perfect, but it's kind of the best way we have to do this type of work, where we try and figure out, does this treatment work? And I would say that is positive, though. It was the first time ever that we'd found that it maybe was doing something, which is good. And if we can prevent some miscarriages, wonderful. And that, I would say, is what we have seen from that first trial I spoke about, is that there is something happening for a small number of women. It seemed to make maybe a bit of difference. And so great, let's go with that. But equally, we need to carry on that research, because unfortunately in medicine, we don't get all the answers at once. And that's true of anything. That's true for cancer, for, heart disease, lots of things. Unfortunately, the process of understanding is slow. So, yeah, it's difficult.
Okay, so first question through. Are you aware of any quality trials using oral versus vaginal micronized progesterone?
Yeah, so there's lots of trials on the go, and I'm trying to copy and paste that article there. I'm going to take a screenshot maybe so I can look that one up for you. I don't know which paper that is specifically, just from the website there, but I will have a look at it. At the moment, what has been found is that no other progesterone made any difference. That's what we're going on currently. There's been what we call systematic reviews, where they combine lots of trials as well, because sometimes what you find is a small effect in one single trial, but lots of trials actually are out there that debate it. So one finds it works, one finds it doesn't. And so what a systematic review does, that's a different type of piece of research. They sort of bring all those trials together and combine the results. And there's been lots of those done in progesterone, and certainly at the moment, the most recent ones that I'm aware of suggests that it's vaginal micronized only that might make a difference. And as I say, I've just shown you that it's very much even that's small differences, but nonetheless, that's what we're going with.
I've just typed in that research. So it's from the Pakistan Journal of Medical Science. Oral versus vaginal micronized progesterone for the treatment of threatened miscarriage.
What year is it from, Louise?
That's what I'm just looking to find.
And I guess, you know, I'd have to read the whole paper before I could comment on that specifically.
Exactly.
But what I would say is that, you know, I mentioned those 2 trials, which are high quality trials. There are lots and lots and lots of studies out there that are not high quality. And as I say, what's really good is when you can then combine all those studies, look at the quality of each study and come up with a conclusion, these review papers. And again, at the moment, certainly the most recent review papers where they've combined all the studies looking at progesterone would suggest that no, oral progesterone is not advised currently.
So 2019 to 2020 it was conducted. The sample size was 136 women.
So very small, yeah.
That's what, yeah, that was what
Yeah.
popped up for me. It was a quite a small sample group.
But it's a good question because again, it may be that we find something different, you know, in future. But at the moment, certainly there is no convincing evidence that oral is equivalent or better. It's vaginal micronized only.
Mm. And I think what you were saying as well, so thank you very much for that question. I think that was,
Thank you.
that's, yeah. I think what is coming up obviously is that this is almost the starting point really of if progesterone does work, perhaps we maybe need to follow it on with tweaking little things, you know, changing it so that we can find maybe a better way that progesterone might work.
And I think, Louise, the key thing is that miscarriage, unfortunately, we know is what's called multifactorial. There are multi-factors involved. And that's what's, in my opinion, what we really need to crack, as it were, as researchers. We need to figure out why people are miscarrying in the first place. You know, what we do currently is we sort of wait till women have had lots of miscarriages, then try lots of things, but actually we don't know why individual women have miscarried, what is their factors, what's their reasons. And again, something like progesterone won't counteract the effects of age, for example, because we know that age unfortunately leads to higher risk of genetic problems causing miscarriage in the baby. So and it's, we don't, maybe Zosha, the geneticist in the call, can tell us later why that is, but you know, it's unlikely progesterone is going to change that risk. So it's then thinking about, as I've mentioned, progesterone probably will help a small number of women, but figuring out which women it is. And equally, if we can't figure out who, just making sure that progesterone is safe to be using on a wider scale, which at the moment, as I say, certainly we seem to think it is, but more research is needed.
Definitely. We seem to have another question coming through. I'm just trying to see. So why has 4 miscarriages been chosen as the cutoff for progesterone without bleeding? If we can say no harm, why not 2 or 3?
Yeah, really good question. So I personally would say we can't say absolutely there's no harm right now. As I've said, certainly we haven't seen any evidence of harm, but we haven't done the types of studies you need to say that conclusively. So that's the first part of what I would say, is that we cannot absolutely say there's no harm at the moment in natural pregnancies, because we haven't done big enough studies on a longer term, you know, to look at outcomes over a long period of time for babies born. But equally, I don't want you to be worried, because at the moment there is no safety concerns that have been brought up. And absolutely, you know, as I say, we're supporting the NICE guidance. The number. So in that last trial, they showed it didn't work. It didn't work. It didn't change the outcome significantly, you know, looking at the numbers. And so that's why a lot of units are not offering it at 3. As I say, we do discuss that in our clinic, but are very clear that there's no evidence that it will make any difference, and there are potential harms. And certainly for women with 2 previous miscarriages, there is no evidence that it makes a difference to take. And again, remembering that this is not about the bleeding group. This is not women who've come in with bleeding. This is women who that's their history and they have no other symptoms and they have found out they're pregnant. There is absolutely no evidence it would make any difference to take it to. I do understand what you're saying, but if there's no harm, why not? But again, I come back to, we don't absolutely know there is no harm. And like anything, you know, unless there's evidence that it works, why would you take something that doesn't work? And as I say, we are offering it for 4 or more. And as I say, in Aberdeen, we are, again, very much wanting to make shared plans with women. If they feel strongly they want to try after 3, we counsel them regarding the evidence, and we will support that. But I would say that, you know, the evidence is quite clear that 2 miscarriages, progesterone's not advised at the moment. And again, it may change, but that's certainly what we know just now.
Mm-hmm. Yeah, it's very difficult, isn't it? Because
It is.
There's not a lot of research and evidence done with women who are pregnant, and especially in the early stages. So,
well, and Louise, what we do know is that taking other hormones, other treatments in those first early weeks have been extremely harmful to developing babies. And that's the balance here. You know, you don't want to be I don't want to be prescribing things for women that might be harmful. And so it's really important that we figure that out. And as I say, it's great that there's been nothing shown in the trials. But that's not quite the end of the, you know, that's not the full assessment, if you like, about harms. And as I say, many units and many, you know, professors, you know, I'm a new consultant, I'm a new, you know, I'm fairly young, shall we say, but very experienced professors, you know, very much debate, should we be giving it at all, even to women with 4 or more, because the trial didn't find a difference. And I think it is difficult because the Lancet recommendations, as I say, to offer for 4 or more really comes from the fact, a bit like that graph I showed you, there seemed to be a bit more benefit for women who did 4 or more. It still wasn't significant, but it seemed to be a bit more effect, and that's why they've gone with we should offer it, and why, you know, I'm supporting that myself. But it's hard. There's really very little evidence to say that it works. And as I say, of course, we want it to work, but these trials were done very well and didn't maybe give us the result we hoped for, particularly the final trial I mentioned.
Perfect. Well, I think that's all the questions that have come through for now. Really great questions. Thank you so much.
Thank you.
And I'm just going to double check on my chat to make sure that we don't have any. No, there's none come through in the chat either. Victoria, just double check there's nothing come through for you.
No, nothing.
Okay, perfect. Well, thank you again very much, Dr. Andrea. And we'll move on to our next speaker in a little minute. I just want to give you a little chance if anybody needs a quick comfort break, grab a quick drink, and we'll maybe start with Dr. Ashley in 2 more minutes, and we'll start with our next discussion, our next topic to present. So I hope you've all had a chance to either have a comfort break or grab yourself a drink. And we're going to move on to our second speaker for today. So I'd like to ask Dr. Ashley Holt Kentwell to turn on your camera and to come and join me. Ashley is a clinical research fellow at the Centre for Reproductive Medicine, and she's going to be discussing what about the men. So this is an update on the evidence for male factors in recurrent miscarriage.
Thank you. I will just share my screen now. Can you see my screen? Perfect. So thank you for your introduction. So my name is Ashley Holt Kentwell, and I also have kind of 2 hats on, in that my background is as an obstetrics and gynecology trainee, and at the moment I'm working in the fertility clinic in Aberdeen as a research fellow. So I have clinical work, and then I'm also doing a postgraduate degree with the University of Aberdeen within the topic of fertility. And today I want to talk about what about the men. So quite often I think research, and I am going to be talking about research a lot as well, because you know, that's part of my role as well, and it's important. So I think quite often the male partner is not necessarily as well sort of investigated potentially in couples having miscarriage, and that's reflected in the research, and I'll go on to talk a bit about why that is. So firstly, I just want to talk a bit about what evidence-based medicine is, and Andrea's already touched on that. And then I thought I would just discuss a few investigations or treatments that you may have heard about that I think would be useful to discuss, and how that might relate to you. So the primary reason that as clinicians we would want to investigate a couple experiencing recurrent miscarriage is to try and identify any underlying condition for which an effective treatment exists, so that we can actually improve the outcome, so reduce a future miscarriage. And it may be that from a patient perspective, you want to have a discussion about what that might mean for a future pregnancy, try and work out what factors may be contributing to repeated miscarriages. And also we would appreciate that we want to acknowledge, you know, the trauma and distress that you may be feeling, and that you may have some personal answers that you also want to ask. So in terms of the male partner, so there are actually very few research studies, so published evidence out there looking specifically at the male partner. And I think the thinking had been that if a woman can get pregnant, then it's nothing to do with the male partner. And I think that mindset is now changing, and more research the research questions are being asked, and the trials are starting to happen. But there are still very few studies. And this is particularly the case when looking at couples experiencing recurrent miscarriage, with respect to looking at how the male partner may be involved in that. So that's just the first thing to mention. And the second important thing that I think is worth mentioning is that even in the fertility clinic, when we're seeing couples who have not been able to get pregnant at all, that the best test for assessing the male partner is actually still under debate. We don't know what that is yet, and I'll go into some of the tests that are sort of coming through that maybe show some potential promise. So just to mention, I said I just touched on evidence-based medicine. So there's a definition there. So evidence-based medicine is a systematic approach to medicine in which doctors and other healthcare professionals use the best available scientific evidence from research to help make decisions about the care of the individual patients sitting in front of you. And NHS and university doctors, we practice in this way. So what exactly is it? So you can see here that it incorporates three different things. So it's putting together that individual doctor's clinical expertise with what the best available external clinical evidence is from research, high quality research ideally, that has been carried out systematically. So that means using the best information to make the clinical decisions. And the aim is to find evidence from the scientific studies that are actually relevant to the couple sitting in front of you. As the doctor, it's our job to understand those studies and appraise them, and decide, you know, whether that study is applicable to the couple sitting in front of you or not. And not all studies will be relevant to you, and even if they are, they might not be good studies. So that's our role, to decide what's applicable and what's not. so the aim is to integrate the evidence with your personal needs, your values, beliefs, and wishes, and come to make a plan together. So why might that be relevant to you? So I think I'm mentioning this because there is a lot of research and a lot of information out there about what treatments maybe have worked for one individual, and I think this can certainly be the case when you typing into Google, for example, something about, say, for example, progesterone, you may find that there's something different happening in America to what we're suggesting here in the UK. So that's why I mention it, because we would not be recommending investigations or prescribing treatments that haven't been proven to reduce miscarriages. If that evidence was there, if there's something that comes later that has been proven to help, then it absolutely would be offered by your NHS doctor. So we have to be cautious, and we also don't want to be offering anything that's going to give false hope. And Andrew's already touched there on the fact that we still don't 100% know whether progesterone is completely safe, and that's why we have to be careful. And I think at this point, I just wanted to mention as well that just to be wary of investigations or treatments that are being offered to you that you have to pay for. So I'm thinking about private clinics, because these are often profit-making organisations. And as I said, if there was proven benefit from these investigations or treatments, we absolutely would be offering them in the NHS. So the first thing I wanted to talk about was semen analysis, which I'm sure that most of you would have heard of as an investigation. So what exactly is it? So I've put up an example report here, and it's a lab test, so carried out by an andrology lab, and the full report takes actually 3 weeks to come back to put together. And as you can see, there are many things that are reported within semen analysis. And in the fertility clinic, where we're seeing couples that haven't had a pregnancy before, we are mainly focused on these two that are in this box. And actually, this is the lab that do this, so they agree that these are the most important. So looking at the concentration of sperm, so the sperm count, are there sperm there? And that's reported as million sperm per mil. And for the value to be normal, it has to be 15 million sperm per mil seen or more. And you can see that this particular result was 68, and that's normal. The other important parameter is progressive motility. So that's looking at whether the sperm are moving, and if they're moving in a forward progressive direction, because we know that those are the sperm that are the ones that are going to fertilize an egg. And we like that to be 32% are moving normally in the sample or higher. And then there are other various things that are looked at. Morphology here is how the sperm looks. So the lab look at the heads, the tails of the sperm, and give a comment on whether there are normal appearances of the sperm. And actually, you only need 4% of the sample to be normal, for the sample to be classified as normal. So there are lots of different things reported in a semen analysis. Now, these results might be relevant to a couple that have not had a pregnancy before, because you can imagine that if there is very few sperm seen in the sample, sometimes we see that there are no sperm seen at all, or maybe the sperm have a very low progressive motility. Those are really important things to find in a couple that haven't had a pregnancy before, because that may then go on to guide further investigations, such as surgical sperm retrieval in where a sample has found no sperm at all, and fertility treatments as well. I'm thinking about IVF, and I'll mention that a bit later. So that's what a semen analysis reports, and a bit about when it might be relevant. So who might be referred for this testing, and who can GPs refer for a semen analysis test? Because often, certainly in the fertility clinic, this would have happened usually before a couple come for their first appointment. So it's recommended for couples that are having difficulty in conceiving. Usually they've been trying for a minimum of 12 months and they don't have a history of any pregnancies. Now, what's probably more relevant to you is what about doing semen analysis for couples experiencing recurrent miscarriage? Now, looking at the evidence in terms of published research, it is very mixed. And some studies found that couples with a history of recurrent miscarriage had abnormal parameters on semen analysis, so things like morphology were low. But other studies actually found that there was no difference at all when they looked at a group who had sadly experienced recurrent miscarriage and compared them to groups who had not experienced recurrent miscarriage. So I cannot give clear guidance on this because there is not enough high quality evidence to suggest that we should be doing semen analysis for everybody. And actually, even for couples where semen analysis is currently indicated, so in this group, there is no guidance on how to interpret a semen analysis. So we actually don't know how to, in terms of the clinical guidance, how exactly does that semen analysis for that that patient, how does that actually, how can we interpret that in terms of how likely that person might be to be able to get their partner pregnant in the future? How does it directly impact things? The guidance is not there in any scenario. So often it's about looking at the full clinical picture. Next, I just wanted to talk a little bit about fertility treatments. So firstly, a bit about IVF. So IVF is where a woman goes through a series of injections to stimulate her ovaries to grow multiple egg sacs that contain mature eggs. And what we do is we do an egg collection. So rather than letting those eggs be released and ovulate, we collect the mature eggs ourselves, and the lab take over and they combine those eggs with their partner's sperm. So the male partner produces a sample on the day of the egg collection, and then the lab keep the eggs and sperm in a very controlled environment in culture, and they closely monitor how things progress. The aim is that the fertilized eggs go on to become embryos, and then an embryo can be transferred back one at a time to the female partner. So that's a very, very brief summary of IVF, but I'm sure that you've all heard of it. So who should be considering IVF? Now, this is the guidance from NHS Grampian. This is actually Scotland wide, and this really comes from the Scottish government, that IVF should be considered for couples who've been trying for 2 years or more who don't have a history of any pregnancies. It should also be recommended for where we've picked up an issue with the semen analysis. So if the sperm count is low, and usually that would be if it's less than 15 million, and there can be other reasons as well, or if there's an identified issue with the female partner. So I'm thinking about someone that has irregular periods where they may need help with ovulation, or if we've identified that one or both of the fallopian tubes are blocked, which would obviously mean that it's going to be difficult to get pregnant. So those are the indications where we would definitely recommend IVF to a couple. And what about for couples who've experienced recurrent miscarriage? So the evidence suggests that IVF, it may reduce the time to getting pregnant, but it does not sadly reduce the miscarriage rate in those couples, and that shows that there are other factors involved. there are many factors that we still don't know about in terms of why miscarriages happen, as I'm sure you are aware. So it's possible that IVF might be reducing the time to getting pregnant, but unfortunately it does not get around miscarriages happening. And IVF is not something to be undertaken lightly. You know, there are couples that I see that fall into these categories, and actually they decide that IVF is not for them, and patients describe it as a roller coaster of treatment. So it's not something to be taken lightly, and that's obviously why we are not recommending that it's for everyone. And then just to go one step on from that, so ICSI, which is an extra part of the IVF process, we recommend in specific scenarios. Again, it's within that same group. And that's actually where the lab identify a single high quality sperm under the microscope, and they inject that single sperm into one of the eggs collected. And the aim of that is to get around any issues with fertilization. So any issues there might be with the sperm actually getting into the egg, the aim is to get around that. And it's not a foolproof method, and actually it's the lab staff that are doing things by eye here, and there is human error. So when would this be indicated? So as I said, it's when there's an issue with sperm count, for example, if there's very low morphology, and usually that's 1% or no normal sperm is seen, that's when this would be recommended. And I'll in my next slide I'll go on to discuss why I've just mentioned ICSI here when I've said that IVF is not going to be useful for couples that have had recurrent miscarriage. There isn't a difference between doing IVF and ICSI if there's not a clear indication for use. So we would only recommend it here in the fertility clinic where there's a male partner issue. Now, the reason I mention this is because you may have heard a bit about hyaluronic acid. So this is essentially, it's a glue that sits on the outside of the eggs, of human eggs. And what we know is that immature or damaged sperm, so sperm that have damage within the genetic material within them, that they have higher rates of DNA damage. The damaged sperm, they're damaged in terms of the genetic material that's within them. And there is a thought process that these sperm can't develop the material that they need to be able to bind to the glue on the egg to be able to fertilize the egg. So there was a study that looked into this, and someone thought, okay, well, what about when we're doing ICSI and IVF if we introduce this glue ourselves? So this was a high quality study where they when the lab were doing ICSI, what they did was they put this hyaluronic acid in the dish where the sperm were, and then they waited to see which sperm attached themselves to this glue. And this was they thought maybe a better way for identifying which sperm could be used to inject into the eggs as part of ICSI. So the selection was happening a different way. Now, they did actually find that this significantly reduced miscarriage rates, but unfortunately, they did not find a significant improvement in live birth rates, and that's what counts is a couple being able to take a baby home. And therefore this study, this is a direct quote, when they compared ICSI with PICSI, which is this method here, it did not significantly improve live birth rates. And actually they didn't mention miscarriage in their summary, because originally they had not been looking at miscarriage, they'd been looking at live birth rates. So again, they've interpreted their own data with caution, and they've said that in no situation at the moment is PICSI recommended, and certainly it's not something that any labs in Scotland I'm aware of, any fertility clinics offer, certainly not the NHS ones. So I thought I'd mention that because you may have heard a bit about that. Next, I want to talk about sperm DNA fragmentation. So there have been many attempts to develop advanced tests of sperm function, and this is on the basis that actually we're starting to think that doing a routine semen analysis is not that useful. And one of the tests that seems to be to keep coming through is sperm DNA fragmentation testing. So first we need to think about how sperm might get damaged. And the idea is that reactive oxygen species, they're very reactive chemicals that are made naturally by the body, that they damage the sperm. And we also know that sperm can be damaged from outside sources, and the obvious ones, which you may not be surprised to hear, are from things such as smoking and alcohol. And there is also a thinking that actually a lot of the time we don't know the reason why sperm gets damaged. So sometimes it's unexplained. So with that in mind, there has been thinking about ways to test for damage. So damage to the genetics within the sperm, the DNA, and there are actually 8 tests available at the moment that measure DNA quality. And there is no evidence which test is better. And at the moment, this is a test that is only available in private clinics because the evidence is not there. And I'll go on to discuss a bit more about that. So particularly within recurrent miscarriage, frustratingly, the evidence is still mixed. So there was some published research that they did identify a relationship. I think this is what is quite clear, is that there is a relationship between sperm DNA damage or fragmentation and the chance of miscarriage. So there's been shown to be a significant increase in miscarriage in patients that have high DNA damage. But this was only seen with one particular type of DNA damage testing. So one of those 8 tests showed this, but when studies looked at other tests, the association actually wasn't there. So you can see this is quite confusing and it is mixed. So this makes it difficult to interpret. How might someone getting this testing, how does that apply in the clinical context, so within the setting of a clinic? So the guidance by ESHRE is similar to NICE. It's produces guidance that's written based on published high quality research, and they have concluded that assessing sperm DNA fragmentation in couples with recurrent miscarriage can be considered for explanatory purposes. So if the test comes back with a high result for DNA damage, then that may be useful to give that couple some answers, but that is based on indirect evidence. And what we don't know is what we do with that information then. So what does that mean for that couple? What can they then do to change what the test results are showing? How does the damage, can it be reversed? What can we do to improve the damage? And actually, would that then improve the miscarriage rate? So would that reduce the miscarriage, that couple having another miscarriage? Now we just don't know the answer. There is a pilot trial, so that's a trial in a very early stage that is looking at the effect of antioxidants, because at the moment there is no evidence that antioxidants help. And I think we also need standardization of the technique. So which of those 8 tests is actually best? Because different research will be using a different test, and then how can you possibly compare those? So I thought this table here was quite useful. This was published in the Lancet, which Andrea mentioned as one of the biggest medical journals. And these recommendations are based on reviews of all of the research that's been published. The guidelines have been assessed, and also there was a UK-wide conference that was held to come to these conclusions. So is there an evidence of association between the test result for DNA fragmentation and miscarriage? So they've said moderate, so that seems reasonable based on what I've said so far. Is there evidence that the association, so does this contribute to miscarriage risk, the result? So they've said probably, but actually there haven't been studies where they have got a group together where they've recruited them and they've then followed them up over time to see what happened. And those are the one of the best types of studies, and that those are not there yet. So unfortunately, when we've said, is there evidence that the test result is useful? What does this mean in terms of whether a couple, in terms of thinking about whether they might experience another miscarriage? It's unclear. And finally, is there evidence that treatment based on the test results for DNA fragmentation, do they improve outcomes? And there has been no treatment yet studied. So what would I recommend actually based on DNA fragmentation? Because what I think what can be said is that it looks like couples experiencing miscarriage, when we do the DNA fragmentation test, that it comes back high. So although we don't offer it in the clinic because we can't recommend a treatment for it or something specific to change that result, what else could you be doing? So definitely stopping smoking, avoiding obesity. So these two have shown direct links between, so smoking and obesity have been shown to cause DNA damage. However, there actually isn't evidence that stopping smoking or losing weight has an impact on the live birth rate in couples experiencing recurrent miscarriage. But for anyone's general health, we would recommend this. There is some suggestion that actually it's worth reviewing prescribed medications in terms of looking at DNA damage. Anti-inflammatories have been shown to have a damaging effect, and also some other medications, so some antibiotics. There is evidence that excessive exercise, and excessive has not been defined, which is not very helpful, can result in DNA damage. So taking regular but not excessive exercise, limiting alcohol intake, again, that's probably not a surprise, and having a balanced diet, so rich in carbohydrates, fiber, vegetables, protein. Those are associated with healthy sperm, and then actually restricting intake of what are called trans fats and sugars. And again, it's a general statement. There isn't anything else specific within diet that can be recommended. And I've already mentioned that actually the evidence for antioxidants at the moment is conflicting, and hopefully the research will come that will look at specific antioxidants to see whether there's clear benefits in improving live birth rates, reducing miscarriage rates or not, so that we can give clear guidance on that. But at the moment, we do not recommend them. So in summary, so I've talked a bit about how, as doctors in the NHS and in the university, we practice evidence-based medicine and why we do that. With couples experiencing recurrent miscarriage, there isn't any evidence that doing semen analysis, fertility treatment, or measuring DNA fragmentation of sperm actually reduces miscarriage rates significantly, and therefore we don't offer them. I've said to take care when you're accessing private investigations or looking online at treatments that may help, and suggested some lifestyle measures that may help. So thank you very much for listening. Andrew, you talked a lot about Tommy's. I'm sure that you've probably all heard about it, but there's lots of useful information there if you wanted to do any further reading, and actually they're the ones doing the pilot trial that I mentioned on antioxidants. So thank you very much.
Thank you, Ashley. Again, really interesting. I think my main takeaway was actually that the male factor alone is not going to have any impact on a recurrent miscarriage, but actually it would be looking at a couple together.
Definitely.
Yeah.
And we would always do that, and I'm sure that Andrew, you do that in the clinic, that it's always about looking at the couple together. But I think what we don't know yet is directly how the male partner may, what investigations do we need to do that are worthwhile, what treatments can we offer to try and improve things. I think this is a question that's only been answered fairly recently. So although things like progesterone for women have been heavily studied, actually the male partner has been sort of left out a bit. So the research is coming through now. But as I said, at the moment, there isn't anything specific that we can recommend apart from those lifestyle factors, which I think most people already know. So nothing groundbreaking from my side, but maybe useful to know as well what actually we're saying is not useful to do.
Well, I think that is very difficult when we are searching for answers. We tend to try and find anything that will somehow back up what we believe to be true. So it's good to have someone who is objective go through all the information and almost filter it out for us, so that we know what's the right information. And do you quite often find that, I'm just thinking of how both yours and Andrea's presentations almost combine. Would you sometimes find that perhaps if people have discovered there is maybe some challenges on both the male and female sides, that they would combine? So maybe I'm thinking like the ICSI with progesterone, for example. There would almost be a combination of treatments.
So I think it depends on the individual couple as to what we'd recommend. We in the fertility clinic do not often see couples with recurrent miscarriage specifically because there is a specialized clinic for those couples. So quite often the couples I'm seeing are they may have experienced they may have experienced miscarriages, but usually not recurrent miscarriage. Usually it's couples that have had no pregnancies at all, or maybe couples that have children who have with a previous partner who are coming through in a new relationship and finding it difficult to get pregnant.
Okay.
But it is always a combination of factors. But if we're offering a fertility treatment, that's a different story in terms of progesterone. Because IVF is an artificial situation, we do manipulate things slightly differently in terms of medication.
That's interesting. So again, another opportunity for you to anonymously ask any questions, either going through the same website again, and this time it will be a different code. So www.menti.com, and then the code is across the top 78079517. And after we finish this Q&A session, we're going to have a little bit of a longer break. We're going to maybe have a little 15-minute break. So time to get yourself maybe something to eat, something to drink, comfort break. And we will have our next speaker, Professor Zosha, starting at about 11 o'clock. So this is just your opportunity to ask any anonymous questions about male factors.
So I wonder if I can come in, Louise, just whilst we're waiting for any questions. So
Please
thanks,
do.
Ashley. That was a wonderful overview, and definitely much more eloquently coming from a fertility specialist who works so in depth in terms of, you know, the history here is that couples have been looked at very much as a couple in fertility, but they haven't in recurrent miscarriage at all. The men really, and even still, you know, I'm sure anyone who's in the audience who has been to a clinic will know that, yeah, we can ask some questions about partners, and we know that partner's age has an influence now. You know, male partner age has an influence on risk of miscarriage as well, whereas it was always thought to be the women before. That's not true, that male partner age is also thought to have a significant impact on and risk of recurrent miscarriage. So I think, Ashley, you highlight that's changing, definitely, but actually, we're way behind in in terms of recurrent miscarriage. We really haven't looked at the male at all, and historically. So yeah, I think it is changing. I know it's disappointing to hear there isn't really anything we can offer at the moment in the NHS, but hopefully what Ashley has shown us is that things are changing. We're understanding more. So there might be again something that we change in future.
So questions come through. If a parent is found to have a balanced translocation of chromosomes, could the NHS offer IVF with pre-implantation genetic testing to select a viable embryo? And I also don't know, I believe that Professor Zosha is going to also be talking about chromosomes.
Yeah, that's my talk.
Perfect.
Fine. I'm happy to come back to that if that question is unanswered.
I would agree with Zosha. I think it's definitely part of Zosha's talk remit.
The simple answer to that is that the NHS don't offer pre-implantation genetic testing at the moment. But I'm sure that Zosha will explain why.
We do.
Oh, sorry.
For translocation, you do.
For translocation, we do.
In very specific situations, but it's not available unless there's a very specific reason for doing it.
Yeah. It's not randomly. It's not available to everybody for every pregnancy. It's just if you've got one of the things I'll talk about.
Okay, perfect. So I think we should possibly leave that question and come back to it if you feel like it's not answered, but I'm sure Professor Zosha will be answering that through her talk. I'll just wait one wee more minute just to make sure there's no other questions, but please feel free to...
Andrew, could I ask you a question? Sorry, Louise.
No, on you go.
Go for it. I hope I know the answer.
I was wondering what your thoughts are on having progesterone blood tests done in the setting of recurrent miscarriage. What your thoughts are on having blood tests to check progesterone levels?
So at what point do you mean, Ashley? What point do you mean? Do you mean when you're pregnant, or do you mean when you're trying to get pregnant?
No, trying to get pregnant. With a history of miscarriage.
Yeah. So again, you're the expert here, Ashley. You're the fertility doctor. I'm not a fertility doctor, but progesterone levels are obviously used to track, for example, ovulation. And so if you're talking about in the context of whilst trying to get pregnant, a lot of the issue with women who have recurrent miscarriages is that's not the issue. The getting pregnant is not the issue.
I just wondered if that's something that you maybe get asked about.
We do, and I'm there's no evidence that we should be doing it, and almost so that test of progesterone to check if you're ovulating or when you're ovulating is kind of not really helpful, because we know that you've ovulated if you're pregnant. And we know that most women having regular periods are ovulating. They don't need their progesterone level checked. And so I would say in our population, I definitely don't recommend it at the moment, and I'm not aware of any research saying that we should be.
I would agree with that.
I think there is an unanswered question about looking at the progesterone levels in women with threatened miscarriage. So the group I spoke about where we're offering progesterone, where they've come with bleeding, there is an ongoing pregnancy confirmed on scan. I do wonder if we need to do some more research there. I do wonder if we should be looking at the progesterone levels there. Is there a way of figuring out who might actually benefit from progesterone? But again, of course, the big issue there is that we know that unfortunately a huge number of miscarriages, it's to do with where we think it's to do with the baby's genes. So again, the progesterone won't help that. But yeah, I do wonder if there's more research needed in that group to figure that out. And again, just to be clear, Ashley's taken us through very clearly there the difference between research and clinical practice. We're not currently doing that in any research studies here at the moment, but it is certainly something, again, that I think is worth, we might do that in future as part of a research project, but at the moment in clinical practice, we do not check progesterone levels. NICE is not recommending that. No unit, as far as I know, is offering that currently in NHS Scotland, at least.
It was difficult with progesterone. I know that it fluctuates throughout the day as well. So
Yep.
this is question is, which time of day do you test it, and how do you interpret the levels? So
What's normal?
Again,
Yeah, we don't
yeah.
know what's normal in early pregnancy, and what's normal for one person might be completely different for another person. What's normal for a twin pregnancy and a singleton pregnancy might be completely different, and that's the real issue. And again, in early pregnancy, before we know if the pregnancy is going to carry on or not, again, it's difficult to know what the progesterone level should be at certain stages. At a stage where you maybe can't see the pregnancy yet, what should it be? When you then see the pregnancy on scan, what should it be? We really don't know. So a lot of unknown questions. But yeah, at the moment, I don't think progesterone levels are helpful right now.
Thank you.
Oh, Louise, you're muted.
I'm on mute. So that's all our questions finished for Ashley. So we'll have a little 10-minute break just now. Victoria, I don't know if you want to pause the recording, just so there's not that 10 minutes of blank air. Please feel free to have a comfort break. Great. And we are starting back the second half of our presentations with Professor Zosha, who's a Professor of Medical Genetics at the University of Aberdeen and an honorary consultant clinical geneticist at NHS Grampian. She's going to be talking about the genetics of early pregnancy loss. Now, I know, Professor Zosha, you were also going to be joined by Dawn O'Sullivan, but I believe it will be yourself today.
Yes, that's right. That's right.
Perfect.
Hello, everybody, and thank you for asking me along. So I have decided, because genetics can be complicated, and I actually really have no idea what knowledge you all come with. I'm going to try and start from what I would think of as the beginning, and accept that a lot of the time I'm working with health professionals who know some of the beginning stuff. So if I lose you, I don't know if there's a way with Zoom that you can kind of wave your hand or say stop. Can you explain that? But I think we've got a wee bit of time today, so maybe it would be, please feel free to do that if I lose you. But I will try and start at the beginning. So we've actually got quite a lot here, which talks about less about recurrent miscarriage and more about just the sort of more common forms of miscarriage, because that sort of sets the scene. So just forgive me if we are coming to the bit about recurrent, but it's halfway through the talk. Okay. And if some of you are sort of familiar with biology, just hang in there. We'll get to the bits that are probably more relevant for you. Now, if this thing will work for me, there we go. So I think many of you will be aware that most pregnancy losses happen in the first 12 weeks. That affects something like 15% of clinically recognised pregnancies. And of those, 50% are caused by what I'm going to call an imbalance of the chromosomes. So we get our chromosomes, we'll talk a little bit in a minute on what a chromosome is, but we get those from our parents, and roughly speaking, we get we have 23 pairs of them, and we get one from our mum and one from our dad in each pair. And if those pairs are kind of matching, then that's what we call balanced, and that's the sort of normal pattern. And then if you get an imbalance due to something missing or something doubled up, that's an imbalance. So we'll show you some pictures, hopefully, to make that a bit clearer. And classically, we used to detect these by simply making a picture of the chromosomes, which I'll show you. And 86% of those common miscarriages happen due to just the wrong number of chromosomes. But sometimes there's a rearrangement happens between two chromosomes. I'll show you pictures of that. And then sometimes there's some rarer stuff. So this is what a chromosome actually is on the left. So you'll see I've got your DNA picture. That's the recipe of life. And it's made up of 4 letters of what I call the DNA alphabet. A, C, G, and T. And those combined together go into making all of our different proteins and making us what we are. So to keep track of that huge piece of DNA, what the body does is it coils it up around these biological lumps called nucleosomes into chromosomes. So for those of you who knit, you know, when you see yarn that's come nicely from the shop in those nice balls, it's all in an order. But it's just one great long string and the ball's there to keep it in order. Well, basically the chromosome's there to do that for the DNA. So on the right here, you can see a picture of the chromosomes, which to get a picture like that, you have to catch them at the right moment, and they do clever magic in the lab to do that by basically stopping growing cells and then stopping them at a moment that the chromosomes are piling up to separate, to make eggs and to make sperm. So most of our cells in our body, we have 2 copies of everything, but in our eggs, we only have 1 of each, and in our sperms, we only have 1 of each. And then that means that when the 2 come together, you get the right number. And the picture there is actually of a man's chromosomes, because what you're seeing there is 22 matching pairs and then 1 pair that aren't matching. And those were called the X and the Y back in history. And it's having the Y, the genes on the Y, that make the programming to make a male. But on the X, normally a girl would have 2 matching X's instead of the X and the Y. But for the rest of this talk, I'm going to ignore that just to try and keep things simple. But you can imagine there, if that's a man's the cells, what we call the progenitor cells that go to make the sperm, there's only 1 of each of these pairs goes into that sperm cell. And then that piles up with an egg that has only 1 of each. And then you get 2 copies of each in the embryo. And that's the general idea. But it doesn't always work out that way because it's a terribly complicated process. And sometimes what happens, so these are pictures taken of chromosomes down a microscope in a lab, just like our lab. You can see on the left, the example I'm showing you there, it's a bit blockier, it's not as stripy, and basically this is a picture that was taken probably about 10 or 20 years ago, whereas the one on the right is a more modern preparation of chromosomes. So in our lab, when our lab does these pictures, they tend to look more like the ones on the right because they've got really good at making long, thin, stripy chromosomes. And they can use those stripes to sort of see where they are on the chromosomes, a bit like a barcode. And these reflect, in everybody, the stripes are by and large the same. And then that's used as a marker to kind of say where we are if we see, for example, pieces missing or pieces doubled up. So on the left here, you've got 3 of chromosome 21. And I imagine most of you will recognize that's what we call Down syndrome, or sometimes it's called trisomy 21. Trisomy just simply meaning 3 bodies of the 21. So this is the commonest cause of what we call a sporadic or a sort of miscarriage by chance. But of course, some of these pregnancies will survive the process of pregnancy and be born into a child with Downs. In fact, the majority miscarry. Then on the right-hand side, what we've got is the second commonest chromosome pattern that causes miscarriage, which is trisomy, 3 bodies again, but this time with chromosome 16. And this is extremely rare to result in a live birth. Typically, this just miscarries. And then you can pretty much get 3 of any of the things, or you can have, if you ended up with 121, you know, that would cause a miscarriage if you ended up with one of the others. And then sometimes you can even get things like this, what we call triploidy. And, you know, in this picture, you can see that there's 3 of everything. And again, that would typically miscarry. So these are the types of imbalances that cause those early miscarriages. Now, what people are more concerned with really in this talk, I think, is probably recurrent miscarriage. And when we start to talk about structural rearrangements, what we mean are where you have the chromosomes, for example, and I'm going to, these are just different examples of structural rearrangements of chromosomes. So in this one, this is the one we're going to talk a lot about. It's called a balanced translocation. It's called balanced because what has happened here, they've said chromosome A, chromosome B. It could be any of the chromosomes, but basically one bit of one has broken off, one bit of the other is broken off, and the two swap over. And then you end up with two chromosomes, one with the wrong bit on the bottom, the other with the other one on the bottom. So for that person, they've got all the chromosomes they need. It doesn't really affect them in any way unless that break happens actually within a gene, and that's pretty rare. But usually it happens between genes. And so for a person born with these chromosomes, for them themselves, it doesn't matter. Around about 1 in 500 people go around with balanced chromosomes and may not know about it. However, when they then go on and have a child with a parent who has normal chromosomes, and then what we're showing here is, if you remember what we said about you only get one of each copy in the egg and one in the sperm. So this, if you imagine on the left, we'll make this the egg, and this is the sperm cell from a man who's got that he would also have a normal one of those and a normal one of those for it to be balanced, because you'd end up with two of everything. But if we just imagine what happens in that egg and sperm, then if for example it piles up and you end up with basically here, this embryo would end up with too much of the purple and not enough of the pink. And so they would have quite a lot of their genes missing, quite a lot doubled up. And typically that causes a miscarriage. Very occasionally it can cause, for example, learning disability and malformations and survive as a live form. We'll talk about when that happens in a few minutes. So that is a possibility. And I know this sounds complicated, but I've got a nice wee video to show you how it works as well. So on the right here, this is a different kind of chromosome structural problem, which is where, normally there's a natural order to the genes down the chromosome, but sometimes a piece in the middle can get flipped over and then join up again. So that doesn't matter in itself because all the stuff's there. But when a baby's made then with that chromosome, when it pairs up with its friend from the other one, then you can end up in a bit of a pickle because the pairing up doesn't work properly. And it's in that pairing up that sometimes you can get loss or gain. So that one's a bit more complicated to understand what the chances of problems in offspring are. But it's just to show you that there are these changes that can happen. And then you can even get these things we call rings. And that's where both ends are missing and the bit in the middle then joins up. And I'm not going to talk about the bit in the bottom right hand corner there just now. So those are just some things that can happen. What I should have also mentioned is that it's not also can happen in the forming of an embryo, that you might just lose the bottom of one of the chromosomes or gain a bit, end up with a double copy of something. And those are things that or the whole chromosome can be lost, but sometimes a chunk of it, and that can be enough to cause a miscarriage as well. Okay, mosaicism is a genetic term that's used when you have on the left here, what we've got is an embryo that's forming, and then an alteration happens in one of the early cells that then multiplies. But actually most of that baby's body ends up with a normal pattern. But what you can, for example, end up with then is a little bit of chromosome 21 of Down syndrome in a bit of the afterbirth, but not in the baby, for example. And these are the things that when we do testing in pregnancies, we have to look out for. But on the other hand, sometimes you can get an embryo that has 3 copies of one of the chromosomes, and then as it's growing, one of the copied cells loses the extra copy, and you end up back with a normal pattern in some of the cells, and then you can end up with a mixture of cells either in the baby or actually in the afterbirth as well, and then that can cause poor growth and so on. But these are rare things, and I'm not going to talk any more about them, but that's the small print about the genetics of kind of more common types of miscarriage. But what I'm going to talk now more about is the ones that cause recurrent miscarriage, and this is probably the stuff that some of you have heard about, and the totally technical term is balanced reciprocal translocation. Reciprocal meaning things are swapped around, but it's people tend to talk about balanced translocation. Now, if our fingers and toes are well crossed here, because I'm going to try and play a video, and if it doesn't work from the NHS computer, then I might ask Louise to try and play it. But let's give it a go. And let's just hope the sound works. Oh dear, this isn't looking good. Let's just give it a go. No. Now, can I just check that you were seeing that, or if I failed to make that visible on the right screen?
When you moved it across, we could see it, and then it went away again. And I can hear it in the background.
Okay, so we've got sound. Let me try. Okay, I'll give it a go. If I move that whole one across to there.
Yeah.
Can you see YouTube now instead of my slides?
Yes.
Okay, right, I'm going to give it a go then.
If you just make it larger.
We can't hear it.
Zosha, because you've put yourself on mute, the sound has come off.
Zosha, can you put your volume up anymore?
I heard that, so you want the volume up. Let's give that a go.
Yeah, it's very quiet.
What I'm going to do, how do I do this?
Zosha, don't worry too much if it's not going to work, because we could always, the session's been recorded, and the link, I guess, people could maybe go to, you know, on their own, I guess, if it's not.
Oh, I know what I can do. Let's try. I have the
link ready to go if you would like me to share it.
Why don't you share it? That's
yeah, so if you stop your share.
Yes.
And I will share it. Okay.
Are made up of millions of cells. Inside every cell lies a nucleus which holds 46 chromosomes. Our chromosomes carry genes which make us into human beings. Our chromosomes are numbered from chromosome 1 to 22, with chromosome 1 being the largest chromosome and chromosome 22 being the smallest. The last pair of chromosomes are the sex chromosomes, with boys having an X and a Y, and girls having 2 X chromosomes. A reciprocal translocation occurs when 2 chromosomes swap a piece of chromosomal material. In this example, a piece of chromosomal material from chromosome 1 has swapped onto chromosome 2, and a piece of chromosome 2 has swapped back onto chromosome 1. This is known as a balanced chromosomal translocation, because no chromosomal material has been lost or gained. Reciprocal translocations can occur between any two chromosomes. Most people with balanced reciprocal translocations are healthy. Families and family members are identified with balanced reciprocal translocations because of investigations following a family history of infertility, recurrent miscarriage, or the birth of a child with birth defects and/or learning difficulties. In order to become a parent, you have to make a mature egg or sperm. Normally, each pair of chromosomes come together, exchange genetic material known as crossing over, and divide. Each parent only hands on half their chromosomes into the egg or sperm. Problems can arise for balanced translocation carriers during this process, as 4 chromosomes have to pair up so that each chromosomal segment is sitting beside its partner chromosomal segment before crossing over and dividing. In this example, the 2 healthy chromosomes could be passed on and the child would be healthy. If the 2 balanced translocations are passed on, the child would be healthy, assuming the parent with the translocation was also healthy. However, there are other possibilities where an unbalanced version of the chromosomes could be handed on, resulting in a baby having too much of one chromosome and too little of the other. In this case, too much of chromosome 1 and missing a segment from chromosome 2. The opposite could also occur, resulting in too much of chromosome 2 and missing a segment from chromosome 1. In some translocations, other unbalanced possibilities can also occur. An individual family risk assessment is needed to work out what your translocation means for you. As a rule, the larger the imbalance, the more likely a miscarriage will result. The smaller the imbalance, the more likely a baby could be born with birth defects and learning difficulties. The majority are unique to each individual family. Your risk depends on the specific translocation that is present in your family. Your local genetics unit will help determine what your individual risk is.
Okay, I'll stop my share and then you can take back over.
Okay, thank you. So I think I have to get rid of that, and then I have to get rid of that. Sorry, just give me a second because my slides have gone back to the beginning. There we are. And then if I share that one, and then I do full screen. That's what worked last time. Does that work? Or have we not got the full screen? Is that okay?
You don't have the full screen yet.
Is
There
that
you
better
go.
there? And can you
Perfect.
still see me? It's
Perfect.
Yeah, is that okay? So I know what I need to do. I just can't see you anymore. Can you? Oh no, I haven't done that right. Never mind. I'll keep going. Can you still see me properly, or is that a full?
Yes,
thing?
all perfect.
Yeah.
Perfect.
Yeah. Okay. So round about 1 in 500 people have one of these balanced translocations, but specific combinations of specific bits swapped over are pretty rare. Now, there are some that happen a bit more commonly than others, and those are the ones that go through that little nipped in bit in the middle of the chromosome that we call the centromere, and that's the bit that's critical for when the 2 chromosomes separate from each other. And with the chromosomes, what can happen, the most common place for the swapping over to occur that's recurrent is when that central bit does the swapping over. So you end up with an extra copy of the Down syndrome chromosome, the 21, or the chromosome 13, which is one for Pato, 18 for Edwards, where you end up with those chromosomes swapped over. And that's what we call a Robertsonian translocation. And so those are the ones that cause Down syndrome to run in the family, for example. but actually, you know, individually, those are still quite rare out of that 1 in 500 group. For everything else, it's a pretty unique situation, and in fact the support group for most of the people who have these types of condition is actually called Unique, but their website is rarechromo.org, and it's a unique pattern for each and every family, generally, apart from those Robertsonian ones. But but there are some generalities that we can use in the clinic. And what we do is we look at whether there's a chance of the most likely thing being a miscarriage if things are swapped over. Happens when there's big chunks swapped over, but it depends which they are. And we can use the pregnancy and family history to guide us as well. And we do an individualized risk assessment for each one of these that we detect by testing in the clinic. If we then are thinking about recurrent miscarriage, basically most genetic origin is not proven in the majority of recurrent miscarriages. It's only about 2 or 3% that are some of these balanced translocations. And there are, you know, people have looked at whether it might be other inherited causes of recurrent miscarriage, but the data is really a bit dodgy about it. So the rest of this talk is going to focus on that balanced translocation situation and how we look for that and what testing we can do to try and change risks. Now, we were asked about pre-implantation genetic diagnosis earlier, and that's what the next bit's about. That's what we I've got some of the studies listed here, but it's probably easiest if we just go on and speak about what it actually is and how it works. So in Scotland, the NHS...
Dosha, sorry to interrupt you. It's just there's a fair bit of background noise. We can hear the person speaking behind you, so it's just in case it's not appropriate for everybody to hear that. So I'm not sure if there's a way to stop that, but just conscious, I'm not sure where you are.
Okay, no, that's fine. I'll just alert them. I don't think they're not. Yeah, I'll just check with that. Hang on a sec. Sorry, Leslie. Your speech is apparently coming through on there, just so you're aware. Yeah. Okay. Sorry. Are you still with me now? Can you still hear me?
Yes.
Yeah. Okay. So, now where did we get to? No, it's not wanting me to change my slides. There we are. Okay, so what we do is we refer to the Glasgow Fertility Centre, where it's a chromosome rearrangement we're looking at, and Edinburgh for single gene PGD, which obviously isn't what we're talking about today, but just to let you know, we can do it. And actually most of what's called pre-implantation genetic diagnosis is something that we do for single gene conditions like cystic fibrosis and Huntington's. There's a lot less PGD done for balanced translocations, but let me just tell you about how it is done, and then we can talk about what kind of how useful that is. So it's a process that involves a lot of appointments up and down. You need to basically use IVF to collect eggs and sperm in the usual way, and this is just showing you how that's done with IVF, but if you want me to go through that in more detail, we can do that. And then what happens is the egg is put with sperms in a kind of in a test tube, and sometimes they use a sort of injection thing to get the sperm in, sometimes they don't, and then the embryos are cultured until you get what's called a blastocyst, and at that point they can use a glass needle to take out 1 or 2 of these cells, and then they're tested in the lab for the presence of the translocation. And then what they do is that while those results are coming back, now the embryos are frozen, and then you kind of wake up the ones that are going back, and the ones that have the pattern of chromosomes that's not desired are not replaced. And that means that anything that isn't used can be kept for another pregnancy in the future. And usually, basically, what happens is the embryos are put in one at a time until they're all used up. And then if a pregnancy doesn't happen, then there can be another 2 cycles to make more embryos. But one of the things with these translocations is we have to discard at least half the embryos. So it means that the IVF process is less efficient than it would be if it was simply a test being done for fertility. So that's a reason why we have to have some rules for who might get PGD. Now, this largely reflects the criteria for IVF, but there are a few differences, and that's because of the fact that we need a lot of embryos to make it work. So I thought you'd be interested to see who would be eligible to get that type of testing. And that's a list kept by the Human Fertilisation and Embryology Authority. It's not an NHS decision. But if you have one of the conditions, and recurrent miscarriage due to translocation is on that list. The referral for the PGD has to be before the 39th birthday of the woman. The BMI has to be, so that's an index of body mass, obviously have height and weight taken into account. And that's because as folks' BMI goes up, the fertility rate falls, and you can modify that by reducing BMI. Anti-Mullerian hormone is one of the key ones that we see as losing, making women ineligible, and that's an index of likely success of the IVF process. What we now do is, if that doesn't fall into the group that we're after, as in the level that we're looking for, what we actually can do now is we offer an in-depth assessment of the number of follicles in the ovary, and then take all that into account in the decision as to whether the couple would be eligible. And then there's some other sort of housekeeping stuff. They have to have been cohabiting at the same address in a stable relationship for a minimum of 2 years, no previous unaffected genetic children as a couple, and one partner has no living genetic child. Those are the ones that often mean that folk aren't eligible. And then they are eligible for up to 3 cycles. So if you've had previous IVF or ICSI for fertility reasons, that gets subtracted from those 3 cycles of PGT. And then there are a number of other stuff, like you've got to be Scottish residents, eligible for NHS treatment, non-smokers, not taking any drugs, not drinking any alcohol, and so on. So those are in line with what is the criteria for fertility treatment in the NHS. Now, people are looking into what might be other genetic causes of miscarriage, and I was interested to find this paper when I was researching and updating stuff for this talk. I was actually, when I looked at the quality of the studies in here and looked at really in detail at what they were saying might be causes that are not found yet, really there isn't any good evidence yet for any specific genes that definitely clearly cause recurrent miscarriage. I think we'll find out about a few in the future, but there's nothing clear, and certainly nothing that's usable in terms of day-to-day medical care. Now, I was really, I suppose, asked to come and speak about what tests we do in the genetics lab for folk who have recurrent miscarriage, and how we do that. So this is really all about how we find balanced translocations. So what the testing has now moved to on efficiency grounds is that we start with tissue from the fetus, usually some of the miscarriage material that comes away following a miscarriage, and we're funded where it's a third miscarriage or a subsequent one. And we use a test called a microarray, which is a much more detailed test than the picture of the chromosomes you saw before. It can be done where with more degraded material. You don't have to have living tissue to do that like we have to for the chromosome picture. And we usually do a quick test called a QF-PCR, which excludes, if we find trisomy 13, 18, or 21, then we go on and ask for parental samples to check for a balanced rearrangement. If we don't find an abnormality of those chromosomes, then we go on and do the microarray, which is a more expensive test. And we usually ask for, as well as the tissue, a blood sample from mum so that we can check that we find abnormalities, that they really have come, that they were present in the miscarriage and not inherited from the mum, because that's important in interpreting what we find. Now, we're not funded to do karyotype pictures of parents and parent samples anymore. In the past, that was what we did, but it's not funded now. And we do that because it's less likely we'd find something and it wouldn't tell us if it was the cause of the fetal loss. So we only can test parents following an abnormal, oh, sorry, Dawn wrote this, but I'm trying to remember what she meant. So can only test parents following an abnormal result on the microarray. And then what would happen is the parent samples would be requested by the lab. So we can't do karyotype pictures on parents as a routine anymore. And those criteria have come in simply on grounds of efficiency. But actually, because we've moved to a microarray, which is a more sensitive test, we can find the pro of that side of things is actually we can find translocations that we might have missed in the past. And that's the end of this section. So I'm going to stop sharing my slides and be open for questions.
Thank you, Zosha. That was really, really interesting. And I think it is really important for people to know which tests there are available currently on the NHS and the reason why those are offered. So that's great. So I'm just going to pop up again the same one for Q&A. So same again, I'm just going to give you the code for www.menti.com so you can ask any questions. The last question from the previous Q&A was answered. Obviously it might have brought up more questions on this subject.
Can I ask a question?
Yeah.
So you're quite right. I think Zosha has beautifully answered that question there and told us all the different criteria. And I just wanted to ask Zosha, is that the same criteria across Scotland for PGT?
Correct.
Yeah.
Yeah, those are Scottish
Just confirming
criteria.
that it's not just Grampian that has that. That is
No.
a national thing.
No.
And just
And
confirming.
we have a national board that mediates if there's a question.
And Zosha, correct me if I'm wrong, are rules about offering genetic testing, so testing the pregnancy tissue from a miscarriage, and the fact that we are no longer allowed to do parental karyotyping is also a national policy across Scotland.
Correct.
Is that correct?
Yes, yes. And in fact, one of the things that's happened only very recently is that although in the past our lab was set up to do, for example, culturing of chromosomes, some of that is now being is more available in less places, so the labs can focus on the stuff they do more of.
Would you still find private clinics offering those services, like the parental karyotype testing?
I'm often asked that actually, and I must admit I thought it was unlikely because of the genetic laboratory needs. But Zosha, I don't know if you know differently.
I was going to say the same thing. I think, you see a lot of private testing available for genetic stuff sort of on the mass market now, but actually that isn't looking at chromosomes. It's stuff that's done with big machine, robotic machines, which you can't do. You can't make chromosome pictures like that. There's no money in it, I suspect. So I suspect that's why the private labs don't usually do that picture making. They aim their products in other in the easier to do stuff.
Okay.
I did wonder if folk wanted to talk about how you might kind of catch material from a miscarriage, and you know how you sort of submit that. I don't know, is that something you could speak about, Andrea? Because I think
Yeah, and Natalie's here as well, and I think one of the key things, I guess, as well, is that we can't always get an answer from the genetic test. So we absolutely offer it, as Sasha says, after a third miscarriage, we can send it, and again, that's a national policy for this testing. And there are certainly a number of cases where, unfortunately, the tests don't work because there isn't enough tissue there, or there's contamination with, you know, the women's cells, and so we can't figure out what's what. And of course, the blood test that we have recently started, again, is helping with that. And I think it's and not to trigger anyone at all, but certainly if you thought you were miscarrying and you know, thought you had passed tissue and you've had 2 previous miscarriages, you know, the Rubislaw staff would be happy to help and advise over the phone, and certainly you could bring in tissue. But as I say, with whether or not you miscarry at home or in hospital, there are still cases where we don't get an answer, and so I think it's important to be prepared for that not every sample will manage to be processed. And again, the earlier samples, Sasha, correct me if I'm wrong, that you know, that the earlier the tissue, that there may not be enough material for us to test.
I'm just seeing a question come through. Twice now, my miscarriage tissue samples have been accidentally destroyed by the NHS Grampian. Training needs to be given around the option to retain tissues for genetic testing. First of all, I'm so sorry that happened. That must have been really traumatic.
As am I, absolutely. I'm really sorry to hear that, and absolutely, we do have training, but I will certainly take that back. Natalie's here as well, who's the charge nurse for the early pregnancy unit here in NHS Grampian, and we will certainly take that feedback forward. And I'm really grateful to you for bringing that to our attention. And yes, you're quite right. It requires a different type of handling. And yeah, we are aware of that. We were aware there had been issues, and thank you for highlighting it again, and we will take that seriously. Thank you.
I'm wondering if ladies who've had 2 miscarriages are given information about, if they have a miscarriage, maybe at home for the 3rd time, how to gather the material. I mean, I'm thinking a plastic bag, clean plastic bag would do. Don't freeze it, just, you know, pop it in the fridge, or keep, you know, don't let it get too hot, and just bring it straight to Rubislaw. I was thinking be the right way to deal with it. And if you have to fish it out the loo, fish it out the loo.
And I guess that's you know, what Zosha's trying to say there is, you know, we would try our best to help send that tissue away, and at least get that test done. And I apologies, Josh, I can't remember if you said this in your slides or not, but equally, I guess it's about expectations as well, because a number of the genetic tests will be normal, you know, that we process and we get an answer for, that we don't actually find anything. And as with a lot of things in recurrent miscarriage, you want to find something that can be fixed and that there's an option for. But you know, I would highlight, whilst I totally agree, it's really, really important that we, as much as we can, because we're obviously very limited in what we can offer, we want to be able to help as many women as possible access these tests, but equally to be conscious that, you know, it's very much, it's very much in a good way. We don't find abnormalities often, but equally I know that can be really disappointing for you when you've sent tissue away for testing.
Absolutely. If you've taken the effort to make sure you collect that tissue, then definitely disappointing that someone's just mentioned there that they also had products accidentally destroyed due to an admin error, but they had good advice over the phone with how to collect it though. And I think that is really important, isn't it? That telephone advice is still there to talk people through how to make it as limited as possible. There is any contamination or any destruction of tissues.
And I think the other part of that, and again, to the anonymous poster, thank you for highlighting that, and I'm so sorry that that's happened to you. And I think the other part of it to highlight as well is that what we think is pregnancy tissue is not always pregnancy tissue. Sometimes it's part of the lining of the uterus, and so sometimes tissue may be sent for testing, but actually, again, it's not actually it's not pregnancy tissue, and that can be really hard to kind of get your head around, and understandably be really disappointing. But unfortunately, just on looking at the tissue, it's not always possible to know, particularly again with very early losses.
Yeah. We have another question. Takeaway box was obviously, I'm guessing, the guidance of how to collect tissue. I'm guessing that's what that must have been.
And I guess that's what Zosha's saying. So if you're at home and you miscarry, because of course it can all happen very quickly and unexpectedly, a clean container to bring it in, we would do our best. Again, as I've said, there are definitely lots of cases where we simply can't get the answer, but we can try. So do feel and again, Rubislaw staff can help you with that. Phone up Rubislaw and yep, as Zosha says, bring in the tissue if need to be from home.
And now we're not culturing. If there's some bugs on the outside surface, that matters less than it did when we were trying to get those cells to grow in the lab. But it's, as I say, anything that just keeps it clean. So I mean, just a fresh plastic bag would work really well as well.
And another question's come through: is this testing limited to the third miscarriage or the third recurrent one?
So I think, Zosha, they mean they're consecutive. So my understanding is it's the third one, not necessarily the third in a row.
Correct.
Okay, so third, not third in a row. Yeah.
It's also perhaps worth mentioning that the testing, once you have 3 or more miscarriages, in general, it's less likely to be a chromosome imbalance that's causing it, as in the common or garden chromosome imbalance. And it's only 2 to 3% of recurrent miscarriages that have these balanced translocations. We put a lot of effort into finding them because it's something we can do about it, and it's one of the few defined causes we have. But actually, most folks don't have anything. On the other hand, I've also heard folks say that if we do, for example, find a trisomy 16 or that sort of thing, then it's an explanation. It gives somebody an explanation. But again, we're less likely to find that once we get up into the 3 or more. Now I'm thinking about the next question.
Another question that's come through: I wasn't told that I could or should collect any pregnancy material after several losses. Could be useful to mention that earlier, maybe on a website perhaps. Well, I think actually that could be really useful for the Rubislaw ward perhaps, if they have any kind of material.
So we have a new recurrent miscarriage leaflet, and of course, as I mentioned earlier at my slides, medicine changes quite rapidly in some ways, but slower in other ways. And things change all the time. Even like the criteria that Zosha's mentioned today may not be what you were told if you've been in Rubislaw even in the last year or 2 years, because things have changed with these genetic testing, what we can send and so forth. So it is hard sometimes to keep up with current advice, but we do have a new leaflet which was just brought out earlier this year. I feel like I want to say April sort of time, and certainly genetic testing is talked about in there. There is a QR code for that. I don't know if Natalie's going to share that in our slides later, but there is a QR code as well, so you can get that online. And certainly we'd be happy to share that with Miss as well, so that it can be used. And we're also very grateful to the Miss team who reviewed that leaflet for us and helped us to make sure that it was as good as we could get it. So it certainly is in that leaflet now, but I'm sorry, you're quite right, we haven't got information on the website. And again, I think until we know about these, I think until we hear from ladies and partners like yourselves who are so very gracious to tell us these things and let us know where things are not quite actually optimal, that's how we then can change. So thank you for highlighting that. And as I say, it is in the leaflet, but we perhaps need to get a better way of highlighting that information for a more public way.
Mm-hmm. Thank you. I really appreciate all of the comments and questions that came. Obviously quite personal to bring those things up. So thank you very much. And I'm sorry again. And I think that was all the questions from that talk. But thank you again, Professor Zosha, as well. I think that's brought up quite a lot of information for people and some ideas to take forward. Our last speaker for the day is Natalie McGonigal. I'm maybe going to give you guys just a 1 minute quick break, just if anyone needs a quick comfort break, grab a drink. We are running a few minutes behind time, but I'm sure that will be okay. I would rather you were comfortable. And then in a little moment, we will start with our final speaker, Natalie McGonigal, who is coming to talk from the Rubislaw ward. I hope you've all had a little chance to either grab a drink, nip to the toilet quickly, and of course, last but not least, we have Natalie McGonigal coming up. Also just to mention that Andrea Woolner is going to be leaving us in a few minutes. So I just wanted to say a really big thank you to Andrea for everything that you've done to put this event together, to bring together lots of people from NHS Grampian and the University of Aberdeen. We really appreciate it, and we couldn't have done it without your help and support, so thank you very much. So, Natalie McGonigal is going to be talking to us today about preconception advice and follow-up after miscarriages in Grampian. She is the senior charge nurse for early pregnancy and the bereavement suite, which is the Rubislaw ward, and she is also a specialist nurse for recurrent miscarriage at NHS Grampian. So looking forward to what she has to share with us today.
Hello, everyone. So that was a really good introduction. Thank you, Louise. That's exactly myself, Natalie McGonigal. Many of you might have met me in my role in Rubislaw. Now, I was trying frantically to attach the QR code for that booklet Andrea spoke about, but my computer
Sorry,
froze.
Natalie.
So, and then I was panicked, I couldn't get the presentation up. I think I've managed to get the presentation up, and I don't think it's got the QR code. I don't think it attached, but let's see. I have a picture of the front screen, and if anyone needs a copy of that booklet that doesn't already have it, then just get in touch with me. Here we go. So is that sharing now? Perfect. So just as Louise said, I'm here to speak to you about preconception advice and follow-up in NHS Grampian after miscarriage. Not quite as scientific as the rest of the talks today have been, but really easily understandable, things that you probably know already, but it's good to have a kind of recap of everything. So We're going to peel it back a little bit and speak about what recurrent miscarriage is, risk factors for it, preconception advice. You'll hear me talk about balance quite a lot, and that means everything that you do must be manageable and achievable, and we're wanting you to be as healthy as you can be and look at your wellness holistically. And then we look at the criteria for follow-up at the end. So recurrent miscarriage is defined differently all over the world. Our COG, so that's the Royal College of Obstetricians and Gynecologists, currently defines recurrent miscarriage as 3 or more consecutive miscarriages occurring at less than 12 weeks pregnancy. ESHRA, so that's the European Society of Human Reproduction and Embryology, use a definition of 2 or more, and the charity Tommy's also recognises that definition of 2 or more. We know that miscarriage is very common. We know that 1 in 4 or 5 pregnancies will end in miscarriage, but recurrent miscarriage, or having 3 or more miscarriages in a row, affects about 1 in 100 couples, so 1% of the currently trying to conceive population. Risk factors we've spoken about already with some of the other speakers. So some of these things we have no control over, such as age, both maternal and paternal. Having previous miscarriages also increases your risk, and then some parental genetics that Sosha spoke about. There's also medical conditions, so antiphospholipid syndrome, that's sticky blood syndrome, anemia, abnormal thyroid function. Those are testing that we offer in recurrent miscarriage care, but also medical conditions that you already have, such as diabetes that's not controlled well. We know smoking is a risk factor, but we also know that smoking in continuing pregnancy isn't healthy either, and can come with its own problems, or being very under or very overweight. So we want that BMI kind of between 18.5 and 30, just as we've heard already. For preconception advice, I wanted quickly to say, when is the right time to try again? And the answer is, there is no right answer. It's whatever writes for you, it's whatever is right for your partner and your family. And sometimes you don't have, or often you don't have a lot of control over that either. Sometimes it's just frustrating and you're trying and nothing's happening. What we want is you to be as healthy as you can possibly be. So we all know that to do that, we need a nice, healthy, well-balanced diet. So all of the 4 main food groups on our plate, at a healthy volume of food. We know that we want to be physically active and get our weight to as healthy as we can do. With all of these things, you know, I don't expect you to start going to the gym 7 days a week, for example. It's taking steps to be physically active. So if that is your job, you are moving around all the time, or if you have a dog and you take it for a walk every day, or you know, things that are simple and achievable. Alongside that healthy diet, the supplementation that we suggest is folic acid. So we all know to take folic acid in pregnancy. The normal level that most people will be required to take is 400 micrograms, but there are instances where you would take a higher dosage, a 5 milligram pill, and that is only available from prescription. So if your BMI is above 30, for example, that's one of those instances. And we want you to be taking that folic acid ideally for at least 3 months prior to conception if possible. On top of the folic acid, vitamin D is the other supplement that we would recommend. And that would just be the normal standard daily dose, which is 10 milligrams, sorry, apologies. Anything on top of those supplements, so if you want to take a pregnancy multivitamin, for example, that's entirely at your own discretion. Smoking cessation, so if you or your partner smoke, then there is help and advice out there to try and stop. I completely appreciate that lots of these things are really difficult to take steps to try and to work towards. And sometimes when I'm giving you this preconception chat, it does sound a little bit preachy. That's not my intention. It is absolutely to get you as healthy as you can be. So you really need to, when you're giving up smoking, be committed and want to give up to be successful, because I appreciate that it's not easy. There are help out there though. You can go to pharmacy and get some help, or there's a link on this presentation. We want you to reduce or stop your alcohol intake during trying for pregnancy. Obviously, we don't want you to be drinking alcohol at all if currently pregnant. We don't want you to be drinking to excess or binge drinking. The occasional glass of wine while trying for pregnancy is probably unlikely to do you harm. So if that's something that you find is relaxing and time for yourself, and you're having, one small glass of wine with a meal once a week, that's probably not the end of the world. And we're going to come on to the next page in a second, but it's important throughout all of this to remember that you are a person or a family, and we are not just all about becoming pregnant again. Obviously, we don't want to be taking any illicit drugs, so nothing that is not prescribed or not researched and that we know is safe to be taken. And additionally, you want to seek help from a professional about other medical conditions to ensure that your medications are safe during trying to conceive, making sure that everything, all the medical conditions you have are as managed as they can be. This is the beautiful booklet that Andrea was speaking about. So Dr. Woolner, Andrea, created it, hence why it's pink. But it's really, really helpful. It's quite lengthy. As she said, it only came out at the start of this year. So there are some of you perhaps on this or watching this back that hasn't got one of these booklets, but they are available from Rubus Law Ward if you need them. And you can drop me a line or give them a call and get one posted out to you. Within the booklet, it goes over all this preconception advice that we're speaking about. It also talks about the service, so the recurrent miscarriage service, what's offered when, the blood investigations that we do, and there's a section at the back about treatments that are not offered as well. So I appreciate everything's going to be backwards on my screen, but there you go. There's also contact numbers on the back. And this slide is just what I was speaking about. It's all in the balance. Our aim in providing lifestyle advice is to get you as healthy as you can be and as whole as you can be. So on top of the physical things that we've spoken about, we want you to also consider your mental and emotional state as well. So obviously it can be, or it is horrendous to go through miscarriage. And the way that many people find helpful to try and process what's happened is through support of your partner, support of your family, friends, professionals or charity partners, organisations such as MIS that can provide that support and advice to allow you to process what's happened. So please make sure that you feel supported. My role as recurrent miscarriage nurse is to provide that support also, so I am available. My job as recurrent miscarriage nurse is only supposed to be on a Monday, but I am there. I have colleagues in Rubislaw. They, you know, everyone wants to provide that support for you, so just reach out and get in touch if you need to. About the balance, we've also spoken about, I don't want anyone to start going to the gym 7 days a week, unless that's your bag, but that is not for everyone. It's not achievable for most people. Equally, in order to lose weight, I don't want anyone going on some fad diet that is not healthy either. Everything in moderation is absolutely how I believe we should live our lives, and make sure that you are taking these steps to become healthy in a healthy manner. Now to follow up after miscarriage. So this is our lovely guidance here, again created by Dr. Woolner, following the Lancet recommendations. The referral process for recurrent miscarriage can be done either through the unit that you were at, so Rubislaw in Aberdeen, or through Dr. Gray's. You can self-refer, so if you have been at home and experienced miscarriages or lived elsewhere, then you can just give Rubislaw a call and they can complete a referral form for you over the phone. Or equally, you can attend your GP and they can send in the referral for us. And excuse this says draft behind, but it's just a nice page from inside that policy that's got an overview of all the follow-up criteria. So after one miscarriage, at the time of diagnosis in all settings, primary or secondary care, this is what is supposed to be provided. So at the top there, we've got offer all women thinking of another pregnancy leaflet from Miscarriage Association. Often we'll just give the cards for Miss and Miscarriage Association for people to look at themselves. Most of you will remember how difficult it is to process all the information we're throwing at you when you're in with us in Rubislaw. It's a lot of information to take in, and it's not necessarily the most appropriate time to discuss trying again. So sometimes we would offer you just that card so you can have a look when you feel ready to have that discussion. We can provide preconception advice also, so discussing smoking cessation, optimizing body weight, supplements, folic acid, vitamin D, and optimizing pre-existing conditions. All women should be offered a telephone follow-up 2 weeks from the point that they're in, the miscarriage is diagnosed. That can be either from ourselves in early pregnancy or your community midwife, or indeed from both. And if you're under the care of the fertility team, you can have a follow-up with them. That bottom section says, where possible, BadgerNet record should record first and subsequent miscarriages for all women. It's actually really important that we document what's happened to you. Obviously, we don't want people contacting you unnecessarily if you have miscarried and we perhaps don't know. But equally, it's important in future pregnancies that we know what's happened in the past. Moving on to 2 miscarriages. So once you're referred to recurrent miscarriage, you will get an appointment at least 6 weeks after miscarriage, where you will get blood investigations for your full blood count, your thyroid function, and that APLS screening. we try and keep that to a Monday afternoon so that I am about, and for the most part it's me that sees yourselves. Also, some of my colleagues do it when I'm on holiday or absent for any reason. We provide preconception advice, give you this bonny booklet, and have a wee chat about recurrent miscarriage in general. Very similar to this talk today. And then you get the results from that blood tests kind of 2 to 3 weeks afterwards. It is absolutely dependent on clinical activity, how quickly we can give you the results. The results themselves come back kind of within a week or just over a week sometimes. If you're in a rush and you need to know, then you can give me a call and I can try and chase it along. But ideally, what we want to do is have this in a manageable way that people get the results 2 weeks later, kind of on a Monday routinely, so that nothing gets missed and it's an equitable service for everyone. If those blood tests come back showing that you've had either of the 2 tests we look at for lupus, for antiphospholipid syndrome, so that's lupus anticoagulant or anticardiolipin antibody. If they come back positive, we repeat that test 12 weeks later. We need to know to show a consistent positive in order to say that you've got this APLS. If your thyroid function or full blood count come back abnormal, then it may be that we ask for more blood tests. It may be that we have to discuss with other departments such as haematology, or it may be that we ask you to attend your GP for some treatment. And we will advise you on that when we phone with the results. If, and for the most part they do, these blood tests come back showing nothing at all, you may get a letter in the post telling you that, and with some nice kind of easy to understand advice on there too. For 3 or more miscarriages, we've got at the top there that microarray for pregnancy tissue at the time of 3rd miscarriage, and then follow up with parental karyotyping if abnormal and the report says to do that. The results of these genetic tests are given usually in our recurrent miscarriage clinic. So that is several weeks past the point of miscarriage. You can phone up Rubus Law if you're very keen to know, and we've not been in touch, and it's kind of several weeks has passed. 6-7 weeks has passed and you haven't got your appointment through for consultant clinic yet. But what I would say is that my staff in Rubus Law are not qualified to interpret the genetic results, and it's far better to get that information when you're at the consultant-led clinic. During your appointment at the consultant-led clinic, you'll be offered a scan outside of pregnancy, 2D or 3D, to look for uterine anomaly. We'll have the discussion about progesterone that Andrea's kindly talked about this morning. And for both 2 onwards miscarriages, you are offered an early scan in any subsequent pregnancy from about 7 weeks gestation, if you so wish to have that. And then just at the very end, thank you very much to the 3 other speakers today. I'm sure you all find their information really, really helpful and interesting. We know that most couples after recurrent miscarriage will go on to have a successful pregnancy, so there absolutely is hope. But whatever you decide, whatever decision you make about the future, whether it is whether you have a successful pregnancy, whether you miscarry again, whether you decide to extend your family via a different method, or indeed, if you decide that you're not going to try again, we're here to support you. People are here to support you. Your friends, family, loved ones, organisations. MIS are excellent at keeping in touch. And I know getting support from kind of external people is not for everyone, but it's really important that you process what's happened and don't just bury it. And I really like the hashtag that's been put along with this event today. You are not alone, because you're absolutely not. And that's the end of me today.
Thank you, Natalie. That was so lovely, reassuring as well, just to remind people there is the support available. I know it can be really daunting to reach out for support, but often that will be one of the hardest steps that you make, is reaching out for that support. And once you have, it will just make you feel supported, make you feel not alone. It's always good to have someone to kind of talk through these things. I was actually wondering, Natalie, do you know if there is an online version or a downloadable version of your recurrent miscarriage leaflet?
There is. There's a QR
Perfect.
code. Now, there is a website called Birth in Grampian.
Mm-hmm.
That is kind of for all maternity services. There should be a section on recurrent miscarriage and early pregnancy and bereavement care. Now, I believe our Rubus Law section has been taken down just as some updates are getting made, but that is usually available.
Perfect.
And the QR codes should be on there.
Great. So as an aside, so while you're finding the website again, www.menti.com, using the code 52283487, if you have any questions for Natalie on any of the services provided in Rubus Law Ward, please pop your questions in. But I just wanted to let you know, everybody who is here today, watching this, participating, we're going to be sending out a follow-up email. So actually, I'm wondering if it might be okay with you guys to pop either the leaflet on as an attachment or a link to go and download it, so that people have access to it quite easily.
Yeah, absolutely. That's not a problem. I can send you the QR code by email.
That'd be perfect. So we can add that onto the email. Obviously, it will take a little bit of time for the email to be sent out. It'll maybe be in the next kind of week or so, but we're going to be putting kind of some of the information together, and some helpful links, for example, to a lot of the services that MIS provide, but also some of the things that have been discussed here today as well. So yeah, you can have a look out for that. Sometimes our emails like to go to junk box, so please check over the next few weeks to see that you receive that, because there will be some additional information in there to help you with the ongoing journey that you have after today. So just wait a couple of minutes and just see if any questions come through. I did have a little message there from Andrea Woolner. She had to pop out early, so she just wanted to say apologies that she had to leave early, and just thank you from herself to everybody coming along and all the speakers as well, which we very much echo. After this Q&A session, I'm going to be talking you through a little bit about the support services that MIS can offer for your ongoing support, which I think will be really helpful as well. Just talking about what Natalie was saying there, it is really important to have that support around you. Great information. Is the NHS guidance on miscarriage care based on consecutive miscarriages? For example, 2 miscarriages, a live birth and a miscarriage.
So for the 2 pathway, it has to be 2 consecutive, but then it's 3 or more regardless of whether they are consecutive.
Okay, that's really interesting. Okay, another question. Oh, same question. Nope, it's popped up here. I had one miscarriage followed by a chemical pregnancy. Does this count as 2 miscarriages? The chemical was discussed with the GP but not recorded anywhere. Can I access those services for 2 miscarriages? That's a good question.
Yeah, and a chemical pregnancy is still a loss, so we absolutely would still count that. Currently, that is our criteria. Yeah.
And I actually wonder if the GP would have recorded that loss on, for example, BadgerNet in the notes. No?
So GPs won't record anything on BadgerNet. They won't start a Badger if you would have to be in touch with a kind of midwifery service or an obstetric service for that.
Okay.
Now they might record it in your medical notes that they have access, but you won't have a Badger record for it. Does that make sense?
Yes, it makes sense. Yeah, that it just wouldn't be logged under a maternity service, but it would still be in your medical history in general.
Yes.
Perfect. Just give it one more minute just to see if any more questions pop up, and then we'll go through some of the support options that MIS can offer. Some of those support options are for today or for the future. That seems to be all the questions coming through. So I will share my screen with you and talk you through some of the support. So further support offered by MIS. We have miscarriage support, where you can access one-to-one appointments with a MIS support coordinator. You can either choose if you would like a male or a female support coordinator. That is entirely up to yourself, but you can request that. We also have pregnancy after loss. So if you go on to try to conceive, if you go on to have another pregnancy following a loss, you can have a one-to-one online appointment with a bereavement midwife from Aberdeen Maternity Hospital. We also have monthly support groups. So these are in-person support groups. One of them is at Rubislaw Church Centre, which is the second Thursday of every month, 7:15 till 9 p.m. And we also have one in Ellen at Rowland's Pharmacy, which is the last Saturday of every month at 10 to 11 a.m. Now, obviously, this is quite a lot of information to take down. All of these details are kept on our social media pages. Our social media pages are always updated with upcoming support groups or upcoming services. And if you would like any information on any of these services, or to either book a one-to-one, request a one-to-one with the support coordinator, if you take down the email that's here at the bottom, info@mis-support.org.uk, you'll be able to request any of those services through that email. On top of that, we also have support packs available. So very much what Natalie was saying, it's all about balance. It's about looking after your mental, emotional health and well-being as well. And that's really what the support packs are there to do, support your mental and emotional health and well-being. So we have support bags, we have memory boxes, we also have pregnancy after loss bags, and these can be posted out to you free of charge. So our social media pages, as I said, one of the best ways to find all of the access to all of our social media pages is if you write down our link tree. So link.ee/miss_support. On that link tree, you will find access to our main Instagram and Facebook pages. Also our MIS private Facebook group. We also have the link to our pregnancy after loss Facebook page, which is run by myself. And we also have a pregnancy after loss private support group too. And really the final option for today is we wanted to offer it if anybody has felt triggered by anything today, or just feels like they need a little discussion, we have the option for a breakout room to chat with one of the MIS support coordinators. So if you would like to be put in a breakout room with one of our support coordinators today, please just stay on the meeting after it's finished, and we will manage to put you hopefully into a breakout room one-to-one. If not, I just really wanted to say a huge thank you to all of our speakers today, who have taken time out of their busy schedules to share their knowledge with us. Also like to say a huge thank you to Victoria Goldie, our operations manager, who's put a lot of time and effort into organising today. We also have some of our support coordinators on today, so thank you very much for joining us. We really hope that this has been beneficial, and that you do find some support from all the different services offered. We will be sending out an email, as I said, so you'll be able to get those documents, some more information and some of the links to some of the important information that you might need. So please look out for that. If not, that's everything from me. Victoria, is there anything else you would like to add?
No, just thank you to you, Louise. You've done a great job.
Oh, my pleasure, my absolute pleasure. Yeah, so basically, if you would like to stay on to chat to a support coordinator, please stay on, and we will